to, it's almost like a pep talk. We wanted a limited number of people, and we wanted to spread the message of pediatric endocrinology. And I'm very, very pleased that this has been going on. And I am really grateful to Dr. Amarnath for carrying out this for the last 2, 3 years, and to keep this program active. And instead of meeting once in 2 years in the past, we are now meeting every 3 months, which shows the amount of interest all the juniors are having. And I'm really, really pleased with the work carried out by ISPE and especially Dr. Amarnath. And I hope you'll have a very good program today. And this is also, as usual, exam oriented. That's what I would like at this stage for all the postgraduates who have enthusiastically joined today. Thank you, and I wish you'll have a very good program.
Before
Thank
we
you, sir.
continue with the program, can I ask
Madam,
all the participants to mute?
I need one more word because previous thing was not recorded. Can you tell once again? All the best for all the candidates.
Yeah.
Just now recording
Before we continue with the program, can I request all the participants to mute your audio because you're interfering with the continuation of the program. Best wishes to Dr. Amarnath and Jaivinder Yadav for continuing this fantastic pediatric endocrinology for postgraduates. And it's a privilege to have Professor Anju Seth, Professor Anurag Bajpai, along with Dr. Medha Mithil, Dr. Aradhana Singh, and it's a wonderful program, and we are really pleased to have all of you here, and we hope all of you benefit from this program. And I also invite Dr. Varuna Vyas and the wonderful postgraduates taking part today, including Dr. Sai Saranya, Dr. Aditya, and Dr. Paridhi Gupta. Best wishes and welcome to the program.
Yeah. Jaivinderji, just 5 seconds time for me. I would like to congratulate Dr. Ahila Madam and also Dr. Anurag Bajpai sir for getting FNB for pediatric endocrinology. So that's the greatest achievement of ISPE. And Ahila Madam, Raghupati sir, and everyone has put their most efforts in so many years. That is coming true. Hats off to you, sir. We congratulate the ISPE and Madam, and especially Anurag sir. Over to Jaivinderji.
Okay. Thank you, Dr. Amarnath. Thank you, sir, for your encouraging words. Now we will be beginning with the first case. So we have 2 cases for the first part, and the examiner for the first 2 cases is Professor Anju Seth. So ma'am is Director, Professor and Head, Department of Pediatrics at Lady Hardinge Medical College, Delhi. And ma'am is doing pediatric endocrinology for more than 15 years, and she has immense experience in the fields of endocrinology, and rickets and calcium disorders are her favorite areas. So now we have 2 cases. First case would be presented by Sai Saranya from AIIMS Jodhpur, and she has been guided by Dr. Varuna Vyas, and Dr. Varuna is additional professor at AIIMS Jodhpur. And second case would be presented by Dr. Aditya. So Dr. Aditya is a student at Chacha Nehru Bal Chikitsaylay, MD student, and who had been guided by Dr. Vedam. So Sai Saranya, you can start with your first case.
Yes.
So Saranya, your slides are visible. Make them from first slide and then you could start.
Yes, sir. Sir, are my slides visible?
Yes, your slides are visible.
Good evening, everyone. Myself, Dr. Saranya. I am presenting a case of vitamin D dependent rickets. I'm a postgraduate resident from AIIMS Jodhpur. Here is the demographic data of the case. 2-year-old female child, resident of Jodhpur. Informant was mother with religion Hindu. Reliability was good. Presented with presented with chief complaints of poor growth noticed from 8 months of age, and from 12 months of age noticed progressive limb deformities in form of wrist widening and bowing of arms with inability to stand and walk. And from 18 months of age, parents noticed excessive irritability of the child with listlessness in the form of excessive crying. And there is difficulty of standing till now. Coming to history of presenting illness, child was apparently growing well till 8 months of age when parents noticed poor weight and height gain. Since 12 months of age, mother noticed initially widening of wrist and lower chest indrawing while breathing. And there is no history of associated coryza during that episodes. History of decreased activity, excessive crying, and least interest in surroundings from last 6 months. There is history of delayed attainment of sitting, currently not even able to stand without support or walk. There is history of recurrent respiratory infections since late infancy, none of them requiring admission, and all of those are managed on OPD basis with oral medications. And there is history of delayed eruption of teeth, that is incisors appeared at 1 year of age. Coming to negative history, there is no history of any fast breathing, noisy breathing, cough, and no history of recurrent vomiting, abdominal distension, greasy stools, no history of any blood in stools, progressive pallor, or any worms in stools, blood in urine, frothy urine or burning micturition, and no history of any excessive clothing or decreased sunlight exposure or any sunscreen usage. And there is no history of any prolonged jaundice at birth, passage of meconium, lethargy, constipation, and no history of any recurrent fractures, polyuria, or voracious feeding, no history of any abnormal body movements, anti-epileptic drug uses, or any dental abscess, dental caries, and alopecia. Coming to treatment history, for these complaints, child has been on OPD follow-up on outside hospital, for which she received multiple oral medications, which include calcium and vitamin D, but parents did not notice any significant clinical improvement. Coming to antenatal history, antenatally, mother received iron, folic acid, and calcium supplementation with no other comorbidities. The child was term normal vaginal delivery with birth weight of 2.8 kgs with smooth perinatal transition. Coming to feeding history, child was exclusively breastfed for first 6 months and started on complementary feeds adequately, and child did not receive vitamin D supplementation during infancy. Child is on After that, child is on home based diet with milk included in the diet. Immunized appropriate for age. Coming to developmental history, there is isolated motor delay with sitting without support achieved at 10 months, crawling achieved at 12 months, and standing with support achieved at 14 months. Till now, 2 years of age, but child could not able to stand without support. Other domains are normal. Coming to family history, she is the firstborn of a non-consanguineous marriage, and there is history of similar limb deformities noted in younger sibling from 8 months of age, and there is also delayed attainment of milestones with signs of rickets in the younger sibling from 10 months of age. The child belongs to lower middle class according to modified Kupuswamy scale. On general examination, the child is alert and active with gross limb and spine deformities. Vitally, the child is stable. Coming to
Saranya, can I just
anthropometry,
ask you to stop here?
yes, ma'am.
Just ask you to stop and let us recapitulate what you have brought out in history.
Yes,
Dr. Varuna is your moderator, right?
yes, ma'am.
Dr. Varuna, would you like to make some comments here for the students?
Yes, ma'am. My video has been disabled, I think, from the moderators.
It is okay, no problem. You can
Okay,
just go
ma'am.
ahead and give your
Yes,
comments.
ma'am. So, ma'am, this child has presented to us with features of florid rickets. And however, this child had already been treated for rickets on multiple occasions. So, and this was by qualified pediatricians and orthopedicians. The parents were going from one doctor to another and just getting vitamin D again and again. And we did not see any other features of which were suggestive of any renal involvement or any features of malabsorption when the child came to us.
Okay, I was going by the history, and if we look at see what we are getting is here is a child who has deformities and poor growth right from early infancy. Yet this is some clues that we get here are this child was exclusively breastfed, and I think birth details were also okay. So you have to think of some disorder which is causing poor growth along with rickets. So just asking you, Dr. Saranya, for the benefit of all the people who are attending here, who do you think, what
Yes,
would be the possible causes that you want to think of? Some disorders that would present with rickets and poor growth right from early infancy,
yes, ma'am.
as your case has.
Yes, ma'am. Since the child is having failure to thrive since early infancy, we have to rule out malabsorption syndromes, ma'am. As vitamin D is fat soluble vitamin which is absorbed predominantly from gut. So first possibility, so we have to rule out malabsorption syndromes, and nutritional rickets might be our first possibility in any case of rickets, ma'am.
That I would go a little beyond that. See, this child started developing symptoms in early infancy, and at that time, child was exclusively breastfed, right? So the
Yes, ma'am.
chances of malabsorption presenting at that age become a little less likely.
Yes,
And
ma'am.
what else would you like to consider? Yes, nutritional rickets certainly, but in a
Yes,
child exclusively breastfed, we don't really expect poor growth to come up purely in nutritional
yes,
rickets.
ma'am. Yes,
So
ma'am.
I would actually consider the
Non-nutrition.
RTAs. RTAs are one conditions you must consider. They can present in early infancy and they can present with failure to thrive in rickets. Of course,
Yes, ma'am.
because supposing it had presented a little later, say during second year or third year onward, then you have to think of malabsorption states, including celiac disease, which tends to be very, very common in North India at least. But
Yes,
I think presenting this early, think of RTA and think of some inherited disorders of metabolism. Let's go
yes,
ahead.
yes, ma'am.
And just one more thing from history. Can you make out some idea whether it's a calcium deficient, calcipenic rickets, or is it phosphopenic rickets? Any clues?
Clues, as there is no involvement of any dental caries, dental abscess. Yes,
The
ma'am.
child is very young, 2 year old.
Yes,
In
ma'am.
general, I would say that phosphopenic rickets tends to present a little later. And if it is presenting so early, it is more likely to be calcipenic rickets.
Yes.
Okay, and one more question for you. This child, if you look at the milestones, the initial milestones till the child started sitting were normal. The milestones
Yes,
were
ma'am.
delayed beyond that, right?
Yes, ma'am.
And what do you think is the cause of motor delay in this child?
Ma'am, in this case, mostly the weakness of bones, matlab decreased mineralization. If history is more towards rickets, in rickets, because of decreased mineralization, there may not be strength in bones.
So,
This might
Saranya,
be.
actually, more than that, the real reason why children with rickets, especially nutritional rickets or calcipenic rickets, tend to present with delayed walking is because of associated proximal myopathy rather than osteopenia.
Yes.
Osteopenia, sure, is there, but is not the cause of delayed walking.
Yes, ma'am.
So, please go ahead with your examination.
From anthropometry, the child weight is 6.8 kg, which is minus 4.82 standard deviations, and length is 68 centimeters, which is minus 6.26 standard deviations, and head circumference is 45 centimeters, which is minus 1.75 standard deviations. From this, child is having underweight and child is having short stature. On head to toe examination, there is a widening of wrist and chest wall showing rachitic rosary and protuberant abdomen, and there is a kyphosis, and there is limb deformities of the radius. So overall, the child is having frontal bossing, wide open anterior fontanelle, rachitic rosary, kyphosis, Harrison sulcus, and bilateral wrist widening, bowing of bilateral forearms and legs, and there is generalized hypotonia. Coming to systemic examination, respiratory examination, there is mild subcostal retractions. On auscultation, there is no added sounds. Other systems examination is within normal limits. So with these history and examination, differential diagnosis, first possibility is rickets. In that also mostly non-nutritional rickets more than nutritional, as the child is having severe limb deformities at early age, and there is family history of similar delayed attainment of milestones and limb deformities, and physical examination signs suggestive of rickets. And as the treatment history is showing, the child has been received so calcium and vitamin D medications, but there is no significant improvement, so no response to medication. All these points favor more towards non-nutritional rickets than nutritional. And our second possibility is renal tubular acidosis. Points favoring are there are limb deformities and physical signs of rickets and short stature, but there is no history of any polyuria, polydipsia, or any dehydration episodes. And our third possibility is chronic kidney disease. Favors in favor are limb deformities, physical signs of rickets, and short stature. But in against, there is no history of any hematuria, proteinuria, recurrent UTI, or there is no history of any prematurity. Coming to fourth possibility, skeletal dysplasia, as the child is having failure to thrive, severe limb deformities, and family history, which should be ruled out on genetic basis. And fifth possibility is malabsorption syndromes, as the child is having failure to thrive and listlessness, but there is no history of any diarrhea, bulky stools, severe limb deformities, and developmental delay, and family history is against these malabsorption syndromes. And last possibility is hypothyroidism, as the child is having failure to thrive, protruding abdomen, and developmental delay and listlessness. But in this, there is only isolated motor delay, and mental status was preserved, and deformities were slightly against hypothyroidism. So the X-rays of this child is showing multiple fractures in different stages of healing with severe osteopenia. And this is the distal end of the radius showing cupping, splaying, and fraying, which is classical of rickets. And this chest X-ray and X-ray of lower limbs suggestive of severe osteopenia. Coming to investigations of this child, outside investigations which were done at 15 months of age showed serum calcium of 8.2, phosphate
आजकल
of
मेरा केएम पोस्टिंग है ना, मैं एक भी दिन जिम में छोड़ दूँ।
ALP 942. IPTS was not documented outside at 2 years of age, that is at the time of presentation to age.
Can I
The
request
child is-
everybody to mute yourselves, please? Everybody who's not presenting, please. Everybody mute yourself.
The child is having serum calcium of 7.75, which is low, and serum phosphate of 2.46, and ALP of 4042, which is elevated, and IPTH of 958, which is also elevated, and 25 hydroxy vitamin D is 723, which is elevated. Based on this, as the IPTH is elevated, which is unlikely towards calcipenic and less likely towards hypophosphatemic rickets, we keep a possibility of calcipenic rickets. As the vitamin D levels was high, we keep a possibility of vitamin D dependent rickets. We have did a activated vitamin D levels also, which is 333 normal levels. And serum creatinine was within normal limits, which is ruling out chronic kidney disease. And VBZ was not suggestive of any acidosis, which rules out renal tubular acidosis. Summary of the case is 2-year-old girl with failure to thrive with isolated motor delay with bony changes persisting despite vitamin D and calcium supplementation with a similarly affecting younger sibling suggestive of an inherited cause of refractory rickets.
So Saranya, just
we-
1 minute. Saranya, just let's just stop here for a moment. So,
Yes, ma'am.
2-year-old girl with failure to thrive, yes, non-nutritional ricket, the single most important parameter that points towards that is repeated doses of vitamin D having been given to the child with no response. Practically,
Yes.
it's a good idea, and when such a child comes to us in the OPD, it's worthwhile to make the child take out all the previous reports, try and arrange them in a serial order, and in between intersperse it with the times when the child has received vitamin D and how much. This exercise is well worth it because you can actually see how the child has responded to the doses of vitamin D that have been given at various points of time. And also because in calcipenic rickets, if you can go back to the investigations of this child, hypocalcemia may not always be evident at all assessments. But if you have done it, if you have plotted the serial values, then it is likely that on one or more occasions you might pick up hypocalcemia, which may not be evident at all times. So these are two reports. I'm sure this child had many other reports, and then one can arrange them in a sequence and see them. So your reports are giving you a good idea. 25 OST is very, very high.
Yes,
What do you think about 125 dihydroxyvitamin D?
yes, ma'am. It was within normal limits, matlab
What do you
slightly.
expect it to happen in a case of nutritional rickets?
In a nutritional rickets, this has to be low or normal, ma'am.
No, it is
25
usually
vitamin.
elevated. It is usually elevated because in nutritional rickets, the PTH levels are high, and PTH mediates conversion of 25 hydroxy to 125 dihydroxyvitamin D. So you expect these to be high. Anyway, continue with your presentation.
So
So,
we
ma'am,
went
can
up
we
for
have the Saranya, can you stop for a while? Can we have the second case? Then we can take the questions for both the cases. She has finished the case.
She
Yeah,
has to
then
finish her last slide, I think.
Yeah,
We can,
yeah,
yes, ma'am.
yeah,
Dr.
yeah,
Jaminda, let her finish her
yeah,
last slide.
yeah.
Yes, ma'am. So we went up with clinical exome, which showed homozygous mutation in exon 8 with CYP27B1, which is suggestive of vitamin D dependent rickets type 1. So we have started the child on oral calcitriol 0.25 micrograms, and the dose was titrated on follow-up, and we have also started calcium and phosphate, but parents were poorly compliant for the treatment on follow-up. These are the investigations we are having on follow-up. At the diagnosis, child is having calcium of 7.75. Serially, though, calcium was almost static and phosphate levels was 2.46, which was static. ALP was improved from the time of diagnosis, but not significantly. And IPTH levels were also initially decreased and then increased. This is because of improper follow-up of the child. The child had 3 consecutive episodes of pneumonia during follow-up, and after the third episode of pneumonia, she succumbed at the age of 2 years and 8 months. Her younger sibling is currently still on treatment and under our follow-up, and he is doing well now, gaining milestones appropriately for age, and his biochemical parameters were also normalizing.
So, Saranya, just I
Yes.
think before you go to take home messages, do you think your biochemical profile and what you get on mutation studies are the two matching? What is the, or is there any inconsistency there?
Ma'am, vitamin D dependent type 1, if there is mutation in 1 alpha hydroxylase, there will be increased levels of 21 vitamin D, and there will be decreased levels of 1 alpha hydroxylase. So it
No,
might be
not 1 alpha hydroxylase. No, you expect
125.
just go back. See, in
Yes,
VDDR, you're saying this is VDDR type 1, right? As per your
yes,
report.
ma'am.
In
Yes, ma'am.
VDDR type 1, what will happen? The 25 hydroxy vitamin D does not get
Does not
converted to
convert to
125
125.
hydroxy vitamin D. So
Yes, ma'am.
here your levels are in the high normal range. How do you
Yes, ma'am.
explain that? Right? Dr. Varuna, would you like to make a comment on this?
Yes, ma'am. So because ma'am, 125 dihydroxy vitamin D levels were in the high normal range, so that created a little bit of confusion for us whether
Yes,
we were dealing with VDDR type 1 or VDDR type 2.
absolutely.
Because 25 hydroxy D was very high, there is a possibility because the precursor was so high that we were getting a normal 125 dihydroxy vitamin D. However, and because PTH was also in a very high range, so that was one possibility. And the second possibility was, of course, that we were dealing with VDDR type 2. And because we felt that VDDR type 1 would be much more responsive to treatment as compared to 2, doing genetics would help us determine the prognosis for the patient and determine the dose with which we have to treat this patient, because if it is VDDR type 2, then we have to give very high doses, and we anticipate a relatively poor prognosis as compared to VDDR type 1. So
Yes,
that
you are
was
right. But the thing is, this child has not responded also. So ultimately, if it was VDDR1, such children would nicely respond if you give them alpha-dol or calcitriol. Any of them would be fine. And those children would respond well. You're right, VDDR type 2 is not expected to respond that well, but VDDR type 2 does have a very heterogeneous kind of a spectrum. And you see both extremes. You do see some patients who perform better than the others. So I just wanted to bring this out, of course, for the students here, that typically in a case of VDDR1, you will not expect 125 dihydroxy vitamin D levels to be so high. Of course, there could be lab issues also. And I was just wondering whether what happened to the child's sibling, and was the sibling also diagnosed as a case of VDDR type 1, or did we repeat the investigation in that child? Maybe what were the 125 dihydroxy vitamin D levels in the sibling? Maybe in this case, this was a odd finding. Second case could have confirmed our diagnosis.
Ma'am,
Yes.
so this patient was poorly compliant, and when they were compliant, like when initially when the treatment was initiated and they were compliant, we saw some improvement in the biochemical parameters and the general well-being of the child. The child became less irritable, started mobilizing little bit, but then they were lost to follow-up and they had relatively poor compliance in between, and that's when the child worsened. And unfortunately we lost this child, but
Okay.
the parents understood the gravity of the disease, and with the second child they have we had done calcium, phosphorus, alkaline phosphatase and vitamin D levels, 25 hydroxy D levels only, and we found that these were compatible with vitamin D dependent Rickets type 1 again. And when this child has been compliant on treatment, we found that he has significantly improved
Okay. So
with consistent treatment.
you did not measure 125 dihydroxy vitamin D in the second child.
Ma'am, we measured 125 dihydroxy D levels in the second child, and they were in the low normal range.
Oh, okay. All right.
But that child was in our follow-up from the very beginning of his symptoms, like from 10 months of age itself. So he did not end up getting repeated
Okay.
doses of vitamin D. And so once we started him on treatment and the parents have been compliant, so he's been gaining motor milestones, also not having any fractures. And his alkaline
All
phosphatase
right.
has come down to 333.
Thank you.
Now.
Thank you, Dr. Saranya and Dr. Varuna, for presenting this case. We'll go ahead with the next case.
Thank you, ma'am.
And thank you, Dr. Varuna and Saranya. Aditya, you can start with your case and try to finish it in 7-10 minutes. Yeah, Aditya, your slides are visible. Make them in presentation mode.
Aditya, go ahead with your presentation.
Slide slow, please. Ankit, can you help out? Ankit.
So he's not responding. I think he has been stuck, sir. He's not opening his video also.
Oh.
Sending him his request, but he's not accepting it.
Madam, can we go ahead with the lecture and then start the second case without wasting much time?
We can do that.
Yeah, thank you so much.
Yeah.
So I will share my slides. Just a second.
Yes.
You need slide starter mode, madam.
Are my slides visible?
Yeah, ma'am,
Slide
your
starter.
slides.
Yeah. Now go ahead, madam. Thank you.
All right. So we will present the second case later. I'll quickly take you all through Rickets, and let's begin by listing what we expect a postgraduate student in pediatrics to know about this topic. We expect you to know the basic pathology in rickets, characteristics, evaluation, and management of nutritional rickets. We expect you to know when to suspect non-nutritional rickets and how to evaluate a child with nutritional as well as suspected non-nutritional rickets. We also expect you to know clinical and lab features differentiating the two major forms of rickets, that's calciopenic and phosphopenic rickets, and finally a little bit about management principles of non-nutritional rickets. So, as you're aware, there are two broad categories of rickets, and that's calcipenic rickets and phosphopenic rickets. In both of them, the common factor that leads to the characteristic findings of rickets is renal phosphate wasting. In calcipenic rickets, this renal phosphate wasting is secondary to the raised PTH levels, which induces phosphaturia, whereas in phosphopenic rickets, there is a primary defect in the renal tubular reabsorption of phosphate. Thus, regardless of whether it is calcipenic or phosphopenic rickets, renal phosphate wasting is the common mechanism which leads to hypophosphatemia, which is the biochemical abnormality which leads to the pathology of rickets. Calcipenic rickets now is also referred to as parathyroid dependent rickets, while phosphopenic rickets as FGF23 dependent rickets. So let's see what actually happens in rickets. So normally what happens in the epiphysis and the metaphyseal end of the bone, we have the chondrocytes laid out in columns, and these chondrocytes undergo a hypertrophy, after which they undergo a apoptosis. Once this apoptosis occurs, this is followed by invasion by blood vessels and bone forming cells. What happens in rickets is that these chondrocytes fail to undergo apoptosis, and this is mediated by hypophosphatemia. Okay, so because these chondrocytes don't undergo apoptosis, they continue to multiply, they become hypertrophic, and this leads to a large mass of chondrocytes. Therefore, you can see the widened wrist, the widened bony ends. That's because of the large collection of hypertrophied cartilage cells which haven't undergone apoptosis. Now, on top of this, there is an inadequate mineralization of the epiphyseal cartilage. So this overgrown cartilage with a leading to a formation of a large irregular mass of cartilage and deposition of osteoid matrix on top of this in a rather disorganized manner ultimately leads to a weak and poorly formed bone. So the basic mechanism is hypophosphatemia, which leads to impaired apoptosis of the chondrocytes, ultimately setting in motion the pathological processes leading to a weak and poorly formed bone. Let's look at this typical case. You've already seen one 17-month-old baby brought with inability to walk, but he has achieved previous milestones at age-appropriate times. No major illness in the past, no medication, no family history of similar illness. Parents had non-consanguineous marriage. This child has weight and height on the 5th centile. He has mild pallor. He has all clinical signs of rickets. Rest of examination is normal. So you've already seen signs of rickets. So what do you think the likely cause is here? And why is the walking delayed? We've already discussed part of it in the previous presentation. This, what I presented to you now, is a very, very typical case of nutritional rickets. And the walking is delayed because of proximal myopathy that these children tend to have. So all of you have seen these kind of cases in your OPD. So such cases need to undergo only basic investigations to confirm rickets. And because nutritional rickets is the commonest cause of rickets, it is perfectly logical to presume these to be cases of nutritional rickets and treat them as such. However, they need to be followed up to see response to therapy. So just a little bit about nutritional rickets, which the nutritional rickets encompasses a spectrum from pure vitamin D deficiency at one end to pure calcium deficiency at the other. Most cases of rickets would have a combination of both in some form or the other. And this slide very beautifully illustrates that. If you see this, just give me a second. Yeah. So if the vitamin, these are the two players, vitamin D and calcium, that impact upon the bone formation. If both of them are normal, or one of them is normal and the other is insufficient, osteoid mineralization takes place at a normal pace. If one of them is normal and other is deficient, or both are insufficient, then the situation is precariously balanced. Or there might be some early biochemical abnormalities of rickets, though clinically rickets may not be overt. Clinically overt rickets presents when either both of them are deficient or one is deficient and other is insufficient. In other words, deficiency of one tends to compensate for the other. If one of them is present in adequate amount, it tends to compensate for the deficiency of the other. But if both are deficient or one is insufficient, then the deficiency cannot be compensated, and this leads to a active rickets, or clinical signs of rickets become evident at this stage. Most of our children would have a combination of both, and because both factors are lacking, it makes sense that when we treat nutritional rickets, we give a combination of vitamin D and calcium. Clinical findings of rickets tend to be subtle in infants under 6 months of age, typically nutritional rickets. So at that age, very often the child may actually present with hypocalcemic seizures. The clinical signs, they tend to become more and more obvious as the child grows older during second half of infancy and during next year or so of life. Okay. Other uncommon manifestations might include stridor and dilated cardiomyopathy. So these patients may actually present to you with CHF. So these signs of rickets, which you are all well aware of, are most commonly seen in late infancy and toddlers. Skeletal findings are again subtle in adolescents, and adolescents with rickets will tend to present with lower limb pain, again with proximal myopathy. So they might present with difficulty in walking, difficulty in climbing stairs, and again at this age, tetany or hypocalcemic seizures become more manifest findings of associated with vitamin D deficiency and rickets. So when you are suspecting, when you see a case of rickets, the level 1 investigations that need to be done in all cases of rickets include calcium phosphate alkaline phosphatase. You need to do a radiological evaluation of wrist and knee, and other investigations can be done if indicated clinically, and these include the LFT, KFT, serum electrolytes, and venous blood gas analysis when you are suspecting other problems, say like RTA. At this level, there is no need to do PTH, 25 hydroxy vitamin D or 125 dihydroxy vitamin D. Very often, we see students do 25 hydroxy vitamin D to confirm rickets, while they may not even do an X-ray of the wrist or knee joint. So please remember, all you need in as level 1 investigation in all cases of rickets are calcium phosphate, alkaline phosphatase, and a X-ray of the wrist and knee. So typical features of nutritional rickets, which you remember is a calcipenic rickets, is a high alkaline phosphatase, a low serum phosphate, and a serum calcium level which may be normal, or in a late case it would be low. And remember my comment from the previous case that it's a good idea to see serial levels of serum calcium if the child has been seen at multiple places, because hypocalcemia may not be manifest on one report. Some important things to remember: you must always try and take serum phosphate level in a fasting state because it tends to be affected by the dietary intake. Whether it is serum phosphate or serum alkaline phosphatase, these levels tend to vary with age. Keep age-related normal values in mind. Look them up if you don't remember. Remember, in all cases of nutritional rickets, the phosphate levels are low. That's because the PTH, which is high in case of nutritional rickets and other forms of calcipenic rickets, tends to induce phosphaturia. So serum phosphate levels are low. Occasionally they may be high because of associated secondary PTH resistance. However, if serum phosphate levels are high, before thinking of PTH resistance, do rule out renal failure, which is a more common cause of elevated serum phosphate level. And serum calcium levels, especially ionized calcium level, tend to be erroneous if you are squeezing the arm or tying a tourniquet, or you're dealing the processing of the sample. So we need to be careful while withdrawing these samples. So how do you treat nutritional rickets? The principles of treatment are derived from the pathogenesis. So minimum recommended dose of vitamin D is 2000 units daily, and it varies by age somewhat. And treatment is recommended for a minimum period of 6 to 12 weeks, recognizing that some children may require longer therapy, and followed by maintenance therapy. Oral calcium, either as a dietary intake or supplement, should be routinely used in conjunction with vitamin D. Remember when I showed you that slide that most cases will have a combination of deficiency or insufficiency of calcium and vitamin D. So makes sense to give them both. And always, as the first case has taught us, must inquire into previous administration of calcium and vitamin D. Okay? Essential to monitor response to therapy, and this is important for two things. One, this will help us detect non-nutritional cases, as an important pointer to non-nutritional rickets would be a non-response to a therapy for nutritional rickets, and this will also help us decide duration of therapy. Other important things to keep in mind when you treat nutritional rickets is that we need to use vitamin D. Do not use calcidiol or calcitriol. Neither of them are indicated. They have short half-life, they are more expensive, they also have more toxicity potential, and more importantly, they do not get stored in body. So please use cholecalciferol or ergocalciferol. In India, most of our preparations are cholecalciferol. So please use plain cholecalciferol for treating nutritional rickets. Remember, both oral and parenteral routes are effective. However, rate of rise of serum 25 hydroxy vitamin D, which is the storage form of vitamin D, is faster with oral administration. And so as a principle, there is no need for parenteral administration in most situations. We have now given up using parenteral vitamin D because most situations, even malabsorption states, respond well to oral vitamin D. Both D3 and D2 are effective. Single large doses, the ones that were in vogue a couple of decades ago, something like 6 lakh units, are not needed. We do not use them anymore, and they might actually be harmful. The recent evidence has demonstrated that both daily and intermittent doses are effective, though rate of rise of serum hydroxyvitamin D does tend to be faster with daily administration. But of course, daily administration is more expensive as compared to intermittent. Both are effective. So there are many organizations that have given the guidelines for treatment of vitamin D deficiency. What we expect our postgraduate students to know are at least the IAP guidelines, which were published in Indian Pediatrics in year 2021. Please look at those, and that is what you should be following in your clinical practice. So now when to suspect non-nutritional rickets? So there are some clinical pointers to non-nutritional rickets, which you should be able to take out on your history taking. So presence of chronic liver or kidney disease, alopecia, failure to thrive, familial occurrence, especially in the setting of consanguinity. Remember, familial occurrence can also happen for nutritional rickets because of similar kind of diet and sun exposure. However, especially in the setting of consanguinity, you must think of inherited disorders of vitamin D metabolism or phosphate metabolism as a possible cause. Presence of cataract, intellectual disability, acidosis, hypokalemia, nephrocalcinosis. These are all important pointers to presence of possible non-nutritional etiology, and most importantly, if there is no response to an adequate treatment for nutritional rickets. So a critical factor message that is important for all of us to internalize is that we must inquire into previous administration of calcium and vitamin D and prepare a serial chart as I mentioned earlier. So if you look at the etiology of non-nutritional rickets, broadly, it could be either calciopenic or phosphopenic. In the calciopenic group, of course, the top two are the nutritional rickets, the other three main disorders are the non-nutritional rickets. So vitamin D malabsorption, which includes, at least in North India, celiac disease is very common, but other small intestinal diseases, presence of hepatobiliary disease, chronic pancreatic insufficiency, all of these can lead to vitamin D malabsorption. Disorders of vitamin D metabolism, the inherited disorders, the various VDDRs, and acquired causes like chronic renal failure, anticonvulsants, which would prevent chronic renal failure. Of course, there might be lack of conversion of 25-hydroxy to 1,25-dihydroxy vitamin D, and anticonvulsants induce metabolism of vitamin D, and distal RTA. These are the important causes of calciopenic rickets. In distal RTA, of course, there is acidosis and there is hypercalciuria. You have the next session on RTA. So this cartoon shows you the important causes of VDDR. So VDDR type 1, the case that we saw, is where there is a impaired conversion of 25-hydroxyvitamin D to 1,25-dihydroxyvitamin D. This is VDDR type 1A. We also have a much rarer VDDR type 1B, where 25-hydroxylase vitamin enzyme itself is missing, but that is much rarer. VDDR type 2 is end organ resistance to 1,25-dihydroxyvitamin D. Okay? So if there is end organ resistance, again, this is VDDR type 2A and 2B. 2A is much more common than 2B. 2A being where there is defect at the VDR receptor site, and 2B is when there is an overexpression of this heterogeneous nuclear ribonuclear protein complex. This HNRPC actually competes with the vitamin D VDR complex for the site or at the genetic site. So it competes with the receptor at the genetic site. So if there is over-expression of HNRPC or lack of expression of VDR, which is more common, you will have VDR type 2. In both of them, we expect a high 1,25-dihydroxyvitamin D level. Very rarely, we also have something known as VDDR type 3, which causes increased metabolism of 25-hydroxy vitamin D. That again is rare. For practical purposes, the most important causes of inherited disorders of VDDR are VDDR type 1, which is because of loss of function mutation of this 1-alpha hydroxylase enzyme, and VDDR type 2 when there's an end organ resistance. So phosphopienic rickets is primarily here, there is an increased renal phosphate wasting. Usually it is because of high levels of FGF23. Now, you might recall FGF23 is produced by the osteocytes in response to elevated serum phosphate level or elevated 125 dihydroxy vitamin D level. And the function of FGF23, in fact, it's a major determinant of serum phosphate level, is to induce phosphaturia. Okay? So there are various kind of inherited disorders which can cause hypophosphatemic rickets. We'll have a look at them in the next slide. Sometimes we also have other disorders like tumor-induced rickets, McCune-Albright syndrome, neurofibromatosis, which can all be associated with increased production of FGF23. In addition to FGF23 induced phosphaturia, there can be primary defects in renal tubular phosphate absorption. The examples of that include Fanconi syndrome and something known as hereditary hypophosphatemic rickets with hypercalciuria. Dietary phosphate deficiency is distinctly uncommon except in premature infants. So most cases of phosphopenic rickets will fit into the first group, that is associated with high levels of FGF23, and some cases would fit in with Fanconi syndrome and HHRH. So these are the various disorders. And XLH, the X-linked hypophosphatemic rickets being the commonest of the lot, where there is a decreased degradation of the FGF23. We also have AD, autosomal dominant and autosomal recessive hypophosphatemic rickets with pretty much similar kind of a biochemical profile. A disorder to keep in mind is HHRH, the hereditary hypophosphatemic rickets with hypercalciuria. What is happening here is there is no defect in FGF23 metabolism. The basic problem is in the sodium phosphate co-transporters, which are responsible for absorption of phosphate from the proximal renal tubule. These there is a decrease in these expression of sodium phosphate transporter because of the genetic mutation. Therefore, the phosphate is not absorbed and there is phosphaturia. And this phosphaturia actually increases the production of 125 dihydroxy vitamin D, which in turn induces absorption of phosphate as well as calcium from the diet. How this differs from the FGF23 mediated hypophosphatemic rickets is that FGF23, along with inducing phosphaturia, inhibits formation of 125 dihydroxy vitamin D. In HHRH, because FGF23 levels are not increased, rather they tend to be decreased, there is a increased conversion of 25 hydroxy vitamin D to 125 dihydroxy vitamin D3. Hypophosphatemia is an inducer of this enzyme, leading to increased absorption of calcium and phosphate from the gut. And this increased calcium leads to hypercalciuria. Important to pick up this disorder because management is completely different. So various studies from our own country have shown the important causes of non-nutritional rickets to be fitting into these three groups: the hypophosphatemic group, VDDR, or distal RTA. So these are the disorders you need to keep in mind when you're looking at non-nutritional rickets. So clinical approach has been discussed. So I will skip these slides because I think we have paucity of time, but we have covered what we need to uncover in history and examination. Look for underlying disorders. Look for underlying renal disease, liver disease. Look for underlying polyuria, polydipsia. Look for alopecia. Look for involvement, similar history in siblings, parental consanguinity. Okay. Look for features of calciopenia. If a patient has tingling, paresthesias, and tetany, it's a straightaway pointer towards calciopenic rickets. Remember, VDDRs tend to present in infancy. RTA again during first couple of years. Hypophosphatemic rickets usually tend to present in an older child. So let's look at the differential diagnosis of rickets. If a child has rickets-like deformity, these are the basic investigation you have to do: X-ray, calcium phosphate ALP, look at serum creatinine. If ALP level is normal, it rules out active rickets. Think of other situations that can mimic rickets, like heel rickets, Brown disease, skeletal dysplasia, hypophosphatasia, and mucopolysaccharidosis. Sometimes they can have skeletal manifestations. One can get confused with rickets. If ALP is high, look for clinical clues for resistant rickets. Do you have any clinical clues for resistant rickets, as we have discussed? If they are present or if they are absent, we should treat this case as a nutritional rickets on the first go and look at the response to therapy. Always repeat ALP and X-ray at 1 to 2 months. Demonstrate healing line. Demonstrate that the calcium and phosphate levels and ALP levels have started normalizing. Okay. If there is a healing, it confirms your diagnosis. You give the complete treatment and give maintenance. If there is no healing, or if you have clinical clues for resistant rickets, then we need to look at PTH. If the PTH is elevated, we need to investigate for calciopenic rickets. If PTH is normal or minimally high, you are likely to be dealing with phosphopenic rickets. So the serum PTH levels will help you decide. But remember, sending serum PTH level, you have to be very, very careful. PTH is a very fragile molecule. You need to take the sample and immediately over ice transport it to the lab for immediate processing, or the plasma needs to be centrifuged, separated, frozen till it is thawed immediately before analysis. If you don't do PTH collection, transport, and assay in a proper way, you will get falsely low values. So your entire algorithm will fail to deliver the right results for you. So important biochemical clues to etiology. Remember, urinary phosphate is high in all forms of rickets except CRF. So high urinary phosphate with a normal PTH indicates phosphate wasting states, while high urinary phosphate with high PTH indicates that phosphaturia is likely to be secondary to PTH itself, as it happens in calcipenic rickets. Hypercalciuria is not very common in rickets. If you do see it, it is likely to indicate a few disorders like HHRH, distal RTA, and rarely some other tubulopathies. Keep in mind, PTH is a fragile molecule, serum phosphate levels are affected by feeding, and look at the age-related normal values. And this is how you differentiate clinically between calcipenic and phosphopenic rickets. Typically, in calcipenic rickets, muscle weakness, bony pain, and tetany, enamel hypoplasia are likely to be present, while these are likely to be absent as phosphopenic rickets. Though sometimes there might be muscle wasting when there is severe hypophosphatemia. Serum calcium levels are invariably normal in phosphopenic rickets, while they tend to be low or sometimes normal. It's a matter of when you're catching it. Serum phosphorus levels are invariably low in both. ALP is elevated in both, more likely in calcipenic, but is also elevated in phosphopenic rickets. PTH is markedly elevated in calciopenic, but tends to be normal or minimally high in phosphopenic rickets. Okay, and osteopenia on your X-rays is much more likely to be found in calcipenic rickets, whereas it is less likely in phosphopenic rickets. This is how a phosphopenic rickets X-ray would look like. We have another case coming. So there are coarse trabeculations, and you would have signs of the cupping and fraying, but the osteopenia is not that marked, as you can make out here. Okay, so a calcipenic rickets, when you have the biochemical hallmarks are normal or low calcium, low phosphate, and a high PTH level. This combination indicates calcipenic rickets, you measure serum 25 hydroxy vitamin D level. If this is low, you're likely dealing with malabsorption or the rare VDDR type 1B. If this is normal in a calcipenic rickets, where nutritional rickets has been ruled out, you look at the acidification test. If it is abnormal, you're dealing with a RTA. If it is normal, so a normal 25 hydroxy vitamin D, no acidosis, look at 125 dihydroxy vitamin D. If dihydroxy vitamin D is low, you are dealing with VDDR type 1, both A and B, or the rare, that is VDDR type 3. If it is high, you are dealing with the end organ resistance or VDDR type 2. Of course, abnormal acidification test indicates RTA. What about the phosphopenic rickets? The biochemical hallmarks here are normal calcium, low or very low phosphate, and normal PTH. In such a situation, we look at the FGF23 levels. Remember, these assays are now available to us, though they may not be available everywhere. But these are available. Elevated FGF23, you have to consider conditions like X-linked hypophosphatemic rickets and other inherited disorders. The McCune-Albright syndrome can become obvious on clinical assessment by presence of the Tafiole spots. If FGF23 is not elevated, we need to test for HHRH by doing the urinary 125 dihydroxy vitamin D and urinary calcium creatinine levels. And then we also in such a situation might like to test for rarer disorders like Dent disease and test for Fanconi syndrome, where there might be a generalized proteinuria, glycosuria, and amino aciduria. These are the management principles for calciopenic rickets. VDDR1, you require, because there is the defect is at the level of formation of 125 dihydroxy vitamin D. They respond well to calcitriol or alpha-dol in physiological replacement doses. VDDR type 2, on the other hand, because it's a stage of end organ resistance, require large doses of calcitriol and alpha-dol, and in severe forms, even oral or even high doses of oral or even intravenous calcium may be required. But the clinical presentation of VDDR type 2 tends to be quite heterogeneous, and some patients have a milder disorder than others. Then, of course, VDDR type 3, very, very rare, large doses of calciferol and calcitriol are required. RTA, there's going to be a separate session. And remember, all cases with malabsorption states and anticonvulsants require supplementation with cholecalciferol with the monitoring of doses to titrate the amount of supplementation. Phosphopenic rickets, most of the disorders which are associated with elevated FGF23, that is the XLD and other hypophosphatemic ricket disorders, require both oral phosphate supplements and active form of vitamin D. Hereditary hypophosphatemic rickets with hypercalciuria should be treated only with phosphate supplements. You should not give these children calcitriol because that is going to worsen the hypercalciuria. And of course, the tumor-induced osteomalacia would require tumor identification and dissection, something that tends to be very, very difficult to do at times. And Fanconi syndrome would require multiple replacements. So before we close, one message: all deformed bones are not rickets. Disorders that are commonly mistaken for rickets include this particular case, which is actually a case of metaphyseal dysplasia, and also mucopolysaccharidosis. So these are my important messages. Few simple clinical clues, including non-response to previously administered vitamin D, help suspect non-nutritional rickets. In absence of these clues, it is practical to treat all cases of rickets as nutritional after radiological and biological confirmation. And a characteristic combination of biochemical findings along with clinical and radiological clues will help reach a diagnosis in patients with non-nutritional rickets. So I'll stop here. Thank you.
Thank you, ma'am, for the comprehensive and very informative lecture. So now we can have the second case. Dr. Aditya, are you ready? You can start presenting your case as we are already running late.
Am I audible?
Yeah.
You are
Okay.
audible. Make your slides in slideshow mode and you can start.
Are my slides visible?
Yeah.
Yeah.
Slideshow. Go for slideshow.
Yes, sir. I have put slideshow, sir.
No, click
Aditya,
that,
you're
click
not
that.
on slideshow.
Click
Sir,
that.
ma'am, I have actually put slideshow, ma'am.
Okay.
Okay, go ahead. We don't
Go
have
ahead.
time to complete within 5 minutes. Yeah.
Good evening to one and all present here. Myself, Dr. S. Aditya from Chacha Nehru Bal Chikitsalaya, here to present for pediatric endocrinology for postgraduates under the guidance of Dr. Medha Mittal. Here is a case of a 9-year, 9-month-old male child who is a resident of Azamgarh, Uttar Pradesh.
Slides
came
are
with a
not
chief
moving.
complaint.
Your slides are not moving.
Who came with the chief complaints of progressive bowing of the legs.
Sir, could you please let me share? I would. Okay.
Yeah, Aditya, you stop and madam will share. You have problem. Yeah.
Okay, Aditya, you please stop. Let me share.
Yes, ma'am.
Can you see my slides?
Yes,
Yes,
Dr.
ma'am.
Medha.
Thank you.
Mitha, you might like to go to slideshow.
Yeah, done.
Yeah, no, okay.
Please go ahead.
Here's a case of a 9-year, 9-month-old male child who is from Azamgarh, Uttar Pradesh. Next slide, ma'am. Who came with the chief complaints of progressive bowing of the legs noticed since 2.5 years of age. History of presenting illness. The child came with the complaints of progressive bowing of the legs noticed since 2.5 years of age, for which initially he was shown to nearby doctors, prescribed special shoes, and was given calcium supplements for 4 to 5 months. Despite that, there was no improvement in symptoms. He took local treatment in the form of oil massages and continued calcium supplements. Next slide, ma'am. And he took no treatment for 2 to 3 years in between. The parents noticed that the child is not gaining height as compared to peers of the same age group. He took vitamin D3 sachet, 6,000 international unit, 1 course from outside and another course from our hospital. In April 2023, he came to endo OPD at around 8 to 8.5 years of age in view of no improvement in symptoms. He was diagnosed as resistant rickets and was being followed up and managed further. Next slide. There was no history of increased frequency and volume of micturition, difficulty in breathing, recurrent vomiting, lethargy, muscle weakness, and fatigue. No history of pain while walking. No history of yellowish discoloration of eyes, abdominal distension, bulky or foul-smelling stools. No history of any long-term drug intake. No history of any abnormal tightening of limbs or tingling sensation. No history of any delayed dentition or dental caries. No history of recurrent respiratory tract infection. No history of any fractures, hair loss, difficulty in vision at night. No history of previous hospitalization. No history of any localized swelling or pigmentation over the skin. The child has fully covered clothes most time of the day and is exposed to sun for about 1 to 2 hours in a day. Antenatal, natal, and postnatal history was uneventful, and nutritional history consumes non-vegetarian diet and calorie deficit for 200 kilocalories with protein deficit of 5 grams, and his developmental history was normal for his age. Family history, he was a product of non-consanguineous marriage. There was history of similar complaints in the mother for which no treatment was taken. So this slide shows the index case with his mother, and the mother has short stature, and the X-ray of knee reveals de novo amalgam in the left knee in mother. He was immunized appropriate for the age, and he belonged to lower middle class. So summary of my history, this is a case of a 9-year, 9-month-old male child who is a product of non-consanguineous marriage, came with the complaints of progressive bowing of the legs, noticed since 2.5 years of age. It was a painless deformity, no response to usual doses of vitamin D supplements, and with history of similar complaints in the mother. So the differential diagnosis, First of all, whether it is calcipenic or phosphopenic. In our case, this was less likely calcipenic because there was no any evidence of tetany nor any fractures, and response to vitamin D was not there. And it was moving more towards phosphopenic because it was a progressive deformity, painless, and there was not associated with weakness, and there was history of similarly affected parent. Examination revealed no pallor-ictus cyanosis clubbing lymphadenopathy in pedal edema. His vitals were found to be normal, and his anthropometry is in the next slide. Next slide, ma'am.
It's not moving now.
No, Medha, it's not moving. Maybe just go out of slideshow and come back again. Yeah, it's moved.
His anthropometry revealed height in -4 standard deviation and weight was -1 standard deviation, and his mid-parental height was 158 centimeter, which was less than third percentile, and target height was 152 to 164 centimeter. And here is the corresponding anthropometry chart. Next slide, ma'am.
It's not moving again. Okay.
On head-to-foot examination, there was a presence of, next slide, ma'am, frontal bossing, bilateral wrist widening, bilateral genu varum and bilateral coxa vera, left leg tibial varum, and on dental examination, there was no any evidence of dental abscess or enamel hyperplasia, and the child had waggling gait. Systemic examination were non-contributory. Case summary, the child came with progressive bowing of the legs noticed since 2.5 years of age, which was a painless deformity with history of similar complaints in the mother. Signs reveal frontal bossing, bilateral wrist widening, coxa vera, left leg tibial varum, bowing of bilateral femur, bilateral genu varum, waddling gait with disproportionate short stature. And the X-ray in the left-hand side reveals cupping and fraying of metaphysis, and bilateral coxa vera and bowing of bilateral femur could be seen in X-ray hip joint. And bowing of bilateral humerus could also be noted with mild osteopenia. Investigations were done which revealed normal CBC, and KFT was also found to be normal. Urine calcium creatinine ratio was normal, and in Rickets profile, serum phosphate was low while ALP was elevated. His PTH was normal, and the pH of the child was also normal. Next slide, ma'am. And so even the X-rays were more towards phosphopenic, because in calcipenic rickets there is marked cupping, fraying is playing, which was less likely in our case, as it was less marked as compared to the top in calcipenic rickets. So differential diagnosis considered were hereditary hypophosphatemic rickets, points in favor were painless bony deformity, history of similar complaints in the mother, low serum phosphate and normal PTH. Hereditary hypophosphatemic rickets with hypercalciuria was less likely because there was no any evidence of hypercalciuria because normal urine calcium creatinine ratio. McQueen-Albright syndrome was also less likely because on examination no evidence of capillate spots were seen, and RT was also less likely as his pH was found to be normal, and CKD was also less likely because the child had low serum phosphate, whereas in CKD they will have high serum phosphate. So the provisional diagnosis is hereditary hypophosphatemic rickets, as there was predominantly lower limb involvement with no response to vitamin D and calcium, with family history of similar deformity in mother. And investigation revealed low serum phosphate and normal PTH, which is found in primary phosphate disorder, and it never occurs in any vitamin D deficiencies.
So Aditya, just stop for a minute. Yeah, so very nicely you have brought out the characteristic features of phosphopenic rickets, relatively late age at presentation. The symptoms that you have taken, the history that you have taken rules out any precipitating causes of rickets. You've taken a history suggestive of malabsorption states. You've taken history of associated disorders like jaundice or renal failure. You have also taken a history of repeated doses of vitamin D administration, again pointing towards presence of a non-nutritional rickets and a family history, which again is a pointer towards non-nutritional rickets. And there is lack of calciopenic symptoms. So lack of calciopenic symptoms, older age at presentation, together and with a predominant lower limb involvement, and a very characteristic biochemical finding where the calcium is normal, phosphate is low, 25-hydroxy vitamin D is low, and ALP is elevated, indicates presence of a phosphate wasting state. Perhaps because there's an isolated hypophosphatemia. Go ahead.
So we calculated the fractional excretion of phosphate, which was found to be 9.7%, and tubular reabsorption of phosphate was 90.3%, and TMP-GFR was plotted on Walton-Bizovitz nomogram, which revealed 1.5 milligram per deciliter, and which indicated there was renal phosphate wasting.
Just one stop here. Actually, fractional excretion of phosphate, what is your comment on fractional excretion of phosphate? What is normal fractional excretion of phosphate? And when do you say there is phosphaturia?
Ma'am, phosphaturia, we will say that is, ma'am, actually, TMP-GFR is a best indicator for it is ideal indicator for telling about excretion of phosphate, ma'am, because it is not at all affected by serum phosphate levels. So
my question was different. My question was fractional excretion of phosphate. What is your comment on fractional excretion of phosphate here?
Ma'am, fractional excretion of phosphate is 9.7%, ma'am. Like it indicates that there is renal phosphate excretion is present. But
there is always some phosphate excreted in the kidney. Is 9.7% normal or is it not normal? That's my question.
Ma'am, it is actually normal, ma'am.
Yes. So let us accept it. No, fractional excretion of phosphate, if this is correct, comes in the normal range. You would consider phosphate abnormal renal phosphate wasting when fractional excretion of phosphate is more than 15%, right?
Yes, ma'am. Yes, ma'am.
Okay. So, and another thing I wanted to tell you, can you show, I believe the line that you have drawn here to show the TMP-GFR, there's a bit of an error here. And I wanted to point it out to you because you must realize, when you have these two vertical lines, which the left line is on actual plasma phosphate concentration and the right one is on TMP-GFR. You can see figures written on both sides of the line of actual plasma phosphate as well as the TMP-GFR. The values that you have to consider are not on the inside of the line, which is what you have done while joining. You have to consider on the outside because it is on outside of the line that the values are given in milligram per deciliter. Inside they are in millimole per liter for both. So this is important for all the students. That if you plot it on this nomogram, Bizovitz nomogram, if you have not shown the footnote here, of course, you have to, if you're doing it in milligram per deciliter, look at the values on outside for both. Okay. So your line would not be like this, it would be drawn in a different way. And maybe your TMP-GFR value would turn out to be different from what you have written here now. Okay. So carry on. Carry on.
So we did genetic test, which revealed PEX gene mutation, X-linked dominant hypophosphatemic rickets, which was likely pathogenic. Next slide, ma'am.
So it confirmed your diagnosis.
Yes, ma'am. So final diagnosis in our case was X-linked dominant hypophosphatemic rickets due to PEX gene mutation, where PEX stands for phosphate regulating endopeptidase X-linked. So the trial was started on adfosfactory and capsule alpha calcidiol, and the monitoring of therapy was done based on the following indicators, in which ALP is a reliable indicator. It should usually normalize by 6 to 12 months of treatment. The other indicators are serum calcium p-test, urine calcium creatinine ratio, and height and weight monitoring should be done in every visit. USG KUB should be done yearly, that is annually should be done to rule out nephrocalcinosis. And normalization of serum phosphate is not the goal of our therapy, because the supplements which we give have usually low T-half.
Aditya, you can just show the follow-up slide. We have lack of time.
Okay, sir.
All these
so
have
the
been
monitoring of
covered
therapy
by...
in our case was the serum ALP was found to be in declining trend, and urine calcium creatinine ratio was found to be normal, which shows that the child is not developing any kind of adverse effect because of drugs. So this X-ray pre-treatment on the left-hand side, which shows there is cupping and fraying could be seen, which is less marked on X-ray post-treatment in January 2024. Thank you.
So I think we have demonstrated two different cases of non-nutritional rickets, and we have discussed approach to a case of rickets, including when to suspect and how to evaluate a case of non-nutritional rickets. I think we need to move on to the next session. If there are any questions, I'll be very happy to take them over email. You can send them to me anytime and I will try our best to respond.
Okay. Thank you. Thank you very much, ma'am. Thank you, Aditya, and thank you, Saranya, Dr. Meda, and Dr. Varuna. Thank you all. Now we will move to the second case. The
For this
second.
presentation. Just wanted to say that here we saw that the tubular reabsorption of phosphate was normal, but since the phosphate is low, we are expecting that all the phosphate would be reabsorbed. That is why even if the TRP is normal, we have to interpret it in the light of serum phosphate.
Yeah.
Thank you.
Yeah, Dr. Meda. Thank you. Dr. Amar, for the second case, please.
Yeah. We thank the team Delhi and team Rajasthan. And now we'll go to the second session. For this session, we congratulate Anurag Bajpai sir for bringing FNB to our ISPE once again. And sir will be the expert. He's well-known speaker, national and international. And for this, the renal tubular, this case will be renal tubular acidosis by Dr. Paridhi Gupta. So guide Dr. Aradhana Singh, madam. She is from UCMS Delhi. Over to you.
Okay, yes.
Okay, so can you see my slides?
Yeah, please go ahead. Yes.
Okay. Good evening, sir. I'm Dr. Paridhi Gupta, second year postgraduate from UCMS Hospital. I'm presenting the case of 4-year, 10-month-old female child resident of Ghaziabad, UP. Resident of Ghaziabad, UP, informant is mother, and the history seemed reliable. My slide is not moving, right?
Ankit, can you help out? Yeah.
Maybe you can show it just like that if there is an issue.
So the child presented with the chief complaints of right lower limb deformity for 2 years, pain in all 4 limbs for 2 years, not gaining height and weight for 2 years, difficulty in walking for 6 months, and increased frequency of micturition since 2 months, and inability to stand or sit on her own for 1 day. So history of presenting illness, the child had a right lower limb deformity since 2 years, which was progressively increasing in the form of right lower limb knock knee, and it was not associated with any trauma or fracture. There was pain in all 4 limbs since 2 years, which was dull aching. Initially, the pain was only in the lower limbs while walking, which progressively increased to involve the upper limb and backache also. And currently, the child was having pain at rest also since 3 to 4 months. The child was not able to gain height and weight since 2 years, as the parents noticed that the child was lagging behind her peers in height and weight. The child had difficulty walking since 6 months. There was difficulty in walking long distances, climbing stairs and running, which was progressively increasing. The child had increased frequency of micturition for 2 months. The child was passing urine 8 to 10 times during the day and 2 to 3 times during the night. There was no pain or burning micturition or no urgency. However, there was increased thirst noticed by the parents. There was inability to sit or stand on her own since 1 day. The child was unable to sit from lying down position or stand. The child was able to move upper limb and lower limb sideways, but unable to lift them off the bed. The child was unable to hold any object in the hand. This episode was sudden in onset, non-progressive, and did not involve any stiffness of limbs. There was no history of suggestive of any muscle spasm, numbness, or abnormal body movements. There was no history of chronic diarrhea, chronic constipation, night blindness, petechiae, or greasy stools. There was no history of craving for salty foods, no history of delayed dentition, dental caries, or abscesses, no history of any fractures, no history of progressive pallor, blood transfusion, or hematinics, no history of any fever, cold, or cough. There was no history suggestive of any cerebral, cranial nerve, or respiratory muscle involvement. On treatment history, the child had prolonged treatment history for pain in legs, lower limb deformity, and difficulty walking in the form of injectable vitamin D, oral calcium, and vitamin D sachet since past 2 years. Wrist X-ray was also done, but which was not available with the child. No blood investigations were done and no hospitalization stay was there. There was no improvement in pain and limb deformity on treatment. The antenatal history of the child was uneventful. Natal and postnatal history was also uneventful, just that the child was low birth weight. The birth weight was 2 kgs. On dietary history, the child was exclusively breastfed till 4 months of age and then started on mixed feeds. Complementary feeding was started at 10 to 11 months of age. Currently, the child eats from family pot, was vegetarian in diet, had a poor appetite. There was no intake of milk or fruits, very less sun exposure, and no vitamin D supplementation during infancy. There was a calorie deficit of 64% and a protein deficit of 38%. The child was vaccinated till 1.5 years of age. Developmentally, all the milestones were attained on time. The child plays with friends and goes to tuition, but currently was having difficulty in walking for 6 months. In all the domains, the child had attained the milestones. Just in gross motor domain, the child was able to climb stairs, run, and jump till 6 months back. Currently, the child was not able to do so since past 6 months. In family history, the child was first in birth order, born out of a non-consanguineous marriage. There was no history of any similar complaint in sibling or family member. In socioeconomic history, the child belonged to a upper-lower socioeconomic class. So the summary on the basis of my history was 4-year, 10-month-old female child born out of a non-consanguineous marriage belonging to a low socioeconomic status, presented with isolated motor delay and poor dietary intake, with progressive increasing deformity of the right lower limb and pain in both upper limb and lower limb, non-responsive to vitamin D treatment, poor weight gain and height gain for 2 years, and difficulty in walking for past 6 months, and increased thirst and urination for 2 months, and sudden onset acute non-progressive paralysis, flaccid paralysis for 1 day.
Okay, so just at this point of time, if you think of all this presentation that you've discussed and you've nicely covered a lot of findings, and I'm sure you're going to discuss the differentials, what are the clear-cut pointer messages you will say that this is not a nutritional rickets, it's most likely a refractory rickets right at the offset. So what are the pointers you're thinking of?
Sir, firstly, the child has taken supplementation, multiple treatments, and still there is no improvement in the symptoms. Also, there is a deformity suggesting of a pathological rickets. And then, sir, currently the child is having acute flaccid type of paralysis, which could be due to hypokalemia. And there is also history of polyuria and polydipsia, which is not present in nutritional rickets.
So classically, if you have anybody who has got severe failure to thrive, polyuria, of course, paralysis is an extreme sort of a scenario which really spills it out. And there is a history of treatment. You, of course, have to think of non-nutritional rickets. So carry on with your differential now based on history.
Yes, sir. So on the basis of my history, I've put the differentials as first was non-nutritional query refractory rickets due to renal tubular acidosis. The points in favor were refractory rickets, failure to thrive, history suggestive of polyuria and polydipsia, and acute onset paralysis. Second could be chronic kidney disease. The points in favor were refractory rickets, failure to thrive, and polyuria and polydipsia. Against were acute paralysis. And third is malabsorption syndromes like celiac disease. Points in favor were refractory rickets and failure to thrive. Points against were polyuria, polydipsia, and no history of any GI complaints.
Can you have polyuria and polydipsia in celiac disease? Something which can explain, and you mentioned that, and also paralysis like picture?
Hypokalemia.
Yeah, so if you have severe hypokalemia, you can have both nephrogenic DI like picture as well as paralysis. So I would still keep, because, and you gave a very significant history of a huge caloric deficit of 68% also. So I think malnutrition / those things will be significant to consider. Yeah. And again, polyuria could be part of hypokalemia. Any cause of hypokalemia will cause polyuria. Yeah, please go ahead.
And the second DD was malnutrition along with nutritional rickets. The point in favor were failure to thrive, rickets, and paralysis. And points against were refractory rickets, polyuria, and polydipsia. And my third differential was GBS. The points in favor were acute flaccid paralysis. But points against were refractory rickets, polyuria, polydipsia, non-ascending, non-progressive type of paralysis.
So based upon this, what are the two most likely possibilities? One, of course, you mentioned RTA. Second possibility, we have to consider, we have seen children with celiac present like that, with severe hypokalemia and neck flop, polyuria. So these two will be a close differential, I would say. You carry forward.
So coming to examination, the patient was lying in bed, sick looking, thin built, was having deep breathing and lower limbs were externally rotated. Vitals were normal. In anthropometry, the child was underweight and was having severe stunting. The mid-parental height was calculated to be 162 and target height was 156 to 168 centimeter. I plotted the same on this graph. And the weight age we calculated came out to be 2 years and height age was 2 years, 6 months, while the chronological age was 4.5 years. So this was suggestive of chronic systemic illness or malnutrition. On general physical examination, pallor was present. There were no signs of icterus, cyanosis, clubbing, lymphadenopathy or edema. There was no frontal bossing. Hair was normal, shiny, non-pluckable. In oral cavity, there were no dental caries, enamel hypoplasia, dental abscesses. Oral mucosa was normal. There were no signs of vitamin A deficiency or white corneal reflex in the eye. In chest, there was no Harrison sulcus, pectus carinatum, or rachitic rosary. However, in extremities, there was bilateral wrist widening, bilateral double malleoli sign, calf tenderness was present, and right genu valgum was present. Spine and genitalia were normal. This is the image of the child showing right genu valgum. In CNS examination, the higher mental functions, cranial nerves, sensory system was intact. Meningeal signs, cerebral signs were absent, and spine and cranium was normal. In motor examination, the bulk was bilaterally symmetrical. Tone was decreased in bilateral upper and lower limb, and neck flop was present. In power, the power was 2/5 bilaterally in shoulder and hip joint, and in elbow and wrist joint, it was 3/5, suggesting of proximal weakness more than distal weakness. In reflexes were bilaterally preserved in all the joints, and superficial reflex was present. Plantars were downgoing. So this was suggestive of symmetrical lower motor neuron type of quadriparesis, proximal more than distal weakness with preserved reflexes without cranial nerve or sensory involvement, suggesting of a myopathy type of picture. The systemic examination was within normal limits. Just in respiratory examination, there was deep breathing, which was suggestive of acidotic type of breathing. So I've already presented the summary on the basis of my history. The additional points on the basis of my examination are that the child had pallor, there were signs of rickets, acidotic breathing, and examination suggestive of a myopathy. So my clinical diagnosis on the basis of my history and examination was non-nutritional refractory rickets with underweight, with severe stenting, with acute symmetrical lower motor neuron type of paralysis suggestive of a myopathy.
Yeah, so
And
just hold on. So based upon these findings, if I want to pinpoint one type of RTA, let's assume that RTA is the most likely diagnosis.
Yes.
What is it most likely to be, a distal or a proximal form of RTA?
Sir, it is most likely to be a distal form of RTA because there is paralysis, and hypokalemia is more prominent in distal RTA, not in proximal RTA.
So hypokalemia at presentation is clearly a hallmark of distal, while on treatment, it's mostly proximal. So I think that's a very, very important point to emphasize. Yeah, you can carry on, please.
So I have already discussed the differentials, which were further confirmed on the basis of my examination, as we found acidotic breathing present, which further suggestive of renal tubular acidosis. And also GBS came down more lower because there were preserved reflexes and there was non-ascending type of non-progressive paralysis. So since my first differential was renal tubular acidosis, we investigated the child for renal tubular acidosis. In serum electrolytes, there was hypokalemia. Potassium was 2 milliequivalent per liter. In ABG, the pH was 7.18, bicarbonate was 7, PCO2 was 18, and base excess was -20. This was suggestive of metabolic acidosis. So to find out the type of metabolic acidosis, we calculated a serum anion gap and it came out to be 11, which is normal. So it was a normal anion gap metabolic acidosis. So it could be due to GI loss or RTA. Since we had no history of GI losses, we considered it as RTA. So to confirm the diagnosis of RTA, we calculated a urinary anion gap, which came out to be 43.3, which is positive, thus confirming our diagnosis of RTA. Now we had to differentiate between distal or proximal RTA. For that, we calculated a urine pH at the time of metabolic acidosis, which was 6.8, which is more than 5.5, thus suggesting distal RTA. Also, we did a spot urine calcium creatinine ratio, which came out to be more than 0.2, suggesting hypercalciuria, which is also present in distal RTA. So we investigated the child for etiology of distal RTA. In ophthalmic evaluation, there were no KF ring, cataract, or dry eye. There was no signs of sensory neural hearing loss. HBsAg was negative. ANA was also negative. And in USG KUB, there was no evidence of obstructive uropathy or nephrocalcinosis. And urine routine microscopy was within normal limits. So for Rickets, we evaluated the child. Serum calcium was low, 7.2. Serum phosphate was 3.6, which was normal. Serum ALP was 241, which was also normal. Serum PTH was 13.2. Serum vitamin D, 25 hydroxyvitamin D was 29.2. And X-ray wrist and knee was suggestive of a bilateral cupping, splaying, and fraying at the lower distal ends of radius, ulna, femur, tibia, and fibula, which are classical signs of rickets.
Can you please go back to the previous slide? I think one of the remarkable points which we have to mention here is a normal ALP. This one only. Yeah. So I think this is a point which you have to emphasize, that alkaline phosphatase will be normal usually in distal RTA. So why is it normal and not high in RTA?
Bone turnover is not increased. In RTA, the cause of rickets is due to chronic metabolic acidosis. There is calcium loss from the bone. So bone turnover is not increased. While in proximal RTA, there is phosphate urea leading to rickets.
So based upon these findings also, you can really say it's more likely going towards a distal rather than a proximal RTA. They carry forward.
In other investigation, the blood counts were normal. LFT and KFT was also normal, and TTG was negative. We also did look for glucose urea, amino acid urea, and phosphate urea to rule out proximal RTA, which came out to be negative. So my final diagnosis on basis of my investigations were distal renal tubular acidosis with rickets with severe stunting and underweight. No secondary cause could be identified, and genetic testing could not be done because of financial constraints. In management, we started the child on potassium chloride infusion till recovery of paralysis, and then shifted to oral potassium chloride. Oral bicarbonate was given 5 milliequivalent per kg per day, and vitamin D and oral calcium supplements were given. At discharge, the muscle power and tone improved over the next 4 to 6 days, and the child was able to sit and stand. And metabolic acidosis also improved. The pH came out to be 7.3, and the serum potassium came out to be 3.5. So on follow-up, after 1 week, the tone, power, and limb pain has reduced, and hypokalemia, metabolic acidosis was controlled. Then the child was lost to follow-up, and when the child came back to us at 7 months, the child was again having neck flop and increased body pain and difficulty walking, and the pH was 7.2 and bicarbonate was 8. So we again restarted the treatment. Then at 9 months, we noticed that the child started walking without support, and lower limb pain had reduced. There was no neck flop, and metabolic acidosis has also improved. And there was no sign of nephrocalcinosis in the kidney. And at 11 months, the child can walk long distances without support, and the metabolic acidosis has improved. So this is the recent X-ray of the child of the lower limb, and we can see the healing line showing healing rickets, white line showing healing rickets. Thank you.
So I think thanks a lot to Pardeep for this wonderful presentation and really highlighting the classical presentation of distal RTA. Dr. Aradhana, you have any further points to add?
No, sir. Thank you, Paridhi. You have done very well. I just wanted to highlight that this child remained undiagnosed. The child received several courses of calcium and vitamin D.
Yeah.
While there were so many pointers of non-nutritional rickets in this child, so one should look at these pointers right at the time of first presentation of rickets. So don't miss any of these pointers.
Yeah, so I think the child had RTA written all over the case and should have been picked up much, much earlier. So that's something which we need to highlight. So Dr. Paradhi, you can maybe stop your slide sharing so that we can continue with the one. Yeah. So Dr. Amarnath, shall we start?
Yes, sir. Thank
Okay.
you, Paridhi and Aradhana Singh, madam, for very good case. Over to you, sir.
Yeah, just give me a second. So we had a wonderful discussion about renal tubular acidosis, which is something which is quite important in terms of clinical practice and has varied clinical presentation. But we have seen so many cases of RTA being missed across board. And a lot of it is because of most of us think that RTA is a very complicated process. It requires a lot of evaluation, difficult to diagnose, difficult to treat. But that's not really the case. And we'll try to cover up over the next 15 to maximum 20 minutes about the various aspects of RTA that you require in terms of evaluation and management, largely from a clinical perspective and with pathophysiology to begin with. So when we talk about RTA, we have to basically look into the renal excretion and handling of acids, how the kidneys handle the proton and the bicarbonate, and these are the two major things, and this is very closely linked to the potassium handling, which makes it very, very important from that regards. All of you can go and have a look at our website with all the content with regards to these, and videos are available there as well. Now, if I talk about bicarbonate handling, most of the bicarbonate which is present in the glomeruli is filtered. We have a huge amount of bicarbonate which is filtered every day, 70 millimoles per kg per day, but a majority of that is actually absorbed at the proximal convoluted tubule, accounting to around 90%. So only 10% goes beyond that perspective. Now, these proximal tubules are also important for absorbing a lot of other factors like phosphorus, amino acids, and glucose. So if you have a problem in the proximal tubule, you will lose a huge amount of bicarbonate on one hand, but you're also going to lose a lot of glucose, a lot of phosphorus, and a lot of amino acids. So you will have a significant phosphaturia, and this phosphaturia will be a major factor causing bone disease, which will occur much earlier with a large amount of increased bone turnover in the setting of a Fanconi syndrome, which is a problem in the proximal tubule in that regards. Now, from there, the bicarb is also absorbed in the distal tubule, although to a lesser extent, and only around 1% of bicarbonate which is filtered is excreted. So if you have a problem in the proximal tubule, you will lose a lot of bicarbonate, resulting in a metabolic acidosis. However, there will be a limit by which you can filter your bicarbonate. So if your bicarbonate level goes below a particular level, and I would say somewhere around 15 to 16 millimoles per liter, you will not be losing any more bicarbonate, and your urine will then become acidic. So proximal RTA is characterized by a self-limiting form of acidosis, which tends to have an acidic urine. Now, if we talk about proton handling, there is hardly any filtration as far as proton is concerned, because proton is something which is impermeable. It's very difficult to cross the membrane. You need to have active transporters to push proton out in the urine, and that is largely done by the distal tubule, where you have got two important activities, the proton potassium ATPase and the proton ATPase, which push it into the distal tubule. Now, proton has a tendency to leak out. There is a big gradient which is being created by these active transport of around 1 to 250. So proton will of course leak out. So you need to have something else to ensure that this proton which has come into the tubule is really taken off from the body. And that something is ammonia, which will really bind with proton to produce ammonium, which will be excreted. So the excretion of proton is largely because of active transport happening at the level of the distal tubule and the ammonia secretion. In conditions where you have a problem in the distal tubule, this ammonia production is defective, so the urinary ammonium is less. Now, if we talk about distal RTA from that perspective, you have a problem in acid excretion. There is no self-limiting process. You can't excrete acid. It will keep on getting accumulated in that regards. So you will have much more severe acidosis as compared to what we are seeing in proximal RTA. And secondly, because you cannot excrete proton out, you will have an alkaline urine. So acidic blood and an alkaline urine means distal RTA. Similarly, for treatment, all you need to do maybe in the initial phase, as we saw in that case, you might need to give a higher dose of bicarbonate of around 4 to 5. But subsequently, if you are able to just nullify the 1 to 2 millimoles per liter every day per kg, you will be able to maintain the acid-base balance. On the other hand, for proximal RTA, you're losing bicarbonate, so you need to have much higher bicarbonate dosing in proximal RTA compared to distal RTA in that regards. So this ammonium excretion is a marker of acidification of urine, and we'll talk a bit when we talk about further evaluation from that perspective. So now if we talk about pathophysiology largely of RTA, we have got the proximal RTA in which the problem is in the proximal tubule. So you will have a self-limiting disease, as I said. As soon as the bicarb goes below the filtration level, you will not filter that. You will have an acidic urine characteristic, and there will be no calcification because you are losing also citrate, which is going to prevent the calcification from happening. So there will be hypercalciuria, but this hypercalciuria would not cause calcification because there is citrate which is present in this regards. Now in distal RTA, the problem is largely in the acidification. So you have a more severe disease with an alkaline urine and you're not having any citrate to help out. So you will have nephrocalcinosis, which is characteristic. Distal RTA is also more likely to have hypokalemia at presentation, which improves with treatment, while proximal RTA does not usually have hypokalemia at presentation, but it worsens, the potassium levels worsens once you give bicarbonate treatment from that regards. I'll not touch base much about type 4 RTA because that's a distinct type of RTA more related to the epithelial sodium chloride channel or the renin-angiotensin-aldosterone system, wherein you have hyponatremia, hyperkalemia, and metabolic acidosis. It is not usually associated with severe metabolic acidosis, and you usually do not have a bone disease in that perspective. So renal tubular acidosis could be distal, as I said, and distal RTA could be genetic because of the problems in all the channels and the transport that I discussed about, or you may have an acquired disorder, and there are a lot of disorders which Paridhi mentioned also in terms of evaluation, especially for SLE, Sjogren's syndrome, Wilson's disease, and there are many other autoimmune and drugs which can cause this disorder, characterized by alkaline urine, a severe course. Isolated disorder may also happen and you will have calcification. While proximal RTA would have a lot of genetic causes, including many which associate with liver disease like cystinosis or tyrosinemia, GSD, and the glucose disorder metabolism, or you can have acquired because of drugs and toxins, characteristically associated with the acidic urine, which is a self-limiting course, glucoseuria, phosphaturia, and amino aciduria, and no calcification. One point to remember is that if you have persistent hyperparathyroidism, you may have a Fanconi syndrome-like picture. So we have had patients who had distal RTA classically, but because of hyperparathyroidism, they also had amino aciduria. So just because you have glucoseuria or amino aciduria, you should not exclude distal RTA at that point of time, and there are other factors which become more important. You may also have a hyperkalemic variant, which is, I won't be discussing too much today because that's beyond the perspective in terms of bones. You can have a problem either in the epithelial sodium chloride channel or the renin-angiotensin-aldosterone system, which is a milder acidosis with hyperkalemia, hyponatremia, which is visible. So in distal RTA, as I said, you have a problem in the distal tubule in these two transporters. Ammonium production is also defective. You will have decreased proton secretion. You will have either a back diffusion, alkaline urine, and low ammonium level, which will reflect into a positive urinary anion gap, which I'll talk a bit later. You will also have hypercalciuria and low citrate resulting in nephrocalcinosis. While proximal RTA, classically, you will have a problem of bicarbonate uria. It may also be associated with other generalized tubular dysfunction of amino acid uria, glucoseuria, citrate uria, and phosphaturia. And you will also have a self-limiting course, and urinary pH would be low in that regards. So now when you face a patient with RTA, the key question you have to answer is it RTA? If it's RTA, what type it is, what is the cause, and how do you manage in that regards? So when should you think of RTA? And that's very, very fundamental to what Dr. Aradhana was talking about. So if you have a child with unexplained growth failure, particularly in the first 3 years of life, which seems to be nutritional pattern, you should always do a blood gas. If you have rickets, which has not responded to multiple courses of vitamin D, if there is, of course, a documented nephrocalcinosis, there is periodic paralysis, there is polyuria, or there is acidotic bleeding, think RTA. Now, if you look at this case, it had 5 out of these 6 cases. And this would have been present for a long time. So very much you need to have a high threshold for considering RTA in these possibilities. So when you talk about RTA, we are talking about three terms. You need to have renal, tubular, acidosis. So all this has to be renal, it has to be tubular, and has to have acidosis. So you need to have acidosis, which is pH has to be low, or a base excess is more. So you have a metabolic acidosis to begin with. Your anion gap is normal. Creatinine is normal because that will indicate a glomerular disorder, and your ammonium excretion is impacted, which is suggested by a positive urinary anion gap. So just to highlight, we had this 5-year-old girl with rickets and polyuria. She had significant failure to thrive, had metabolic acidosis and alkaline urine. Somebody labeled it as renal tubular acidosis. But when we saw the child, she had a very high phosphorus, and the problem was that a creatinine was not assessed. So before you think of RTA, definitely look for a glomerular cause. So more common causes have to be excluded before we go ahead with evaluation. This was really a renal failure to begin with. Now, anion gap is a very, very important investigation when you're classifying acidosis, metabolic acidosis. It's basically the difference between unmeasured negative ions and unmeasured positive ion. In other terms, we can say it's the difference between sodium, which is the measured positive ion, versus chloride and bicarbonate, which are the measured negative ions. In conditions, you have accumulation of organic acids like diabetic ketoacidosis, organic acidemia, you will have elevated anion gap, which is classically there. While in conditions where you have loss of bicarbonate, like diarrhea or proximal RTA, or increased proton load like distal RTA, you will have a normal anion gap because chloride is going up in that regard. So really, anion gap will help you classify both situations. So we have a 12-month-old girl with failure to thrive. She has metabolic acidosis. The next step, of course, is to look at anion gap. So we've got sodium, potassium, and chloride, and we have to get the bicarbonate. So the anion gap in this case is 22. So this is an increased anion gap situation. I'm not going to think of RTA. This is something else, and we found it to be a form of organic acidemia, and ketones was also positive. So anion gap is the first part to look at when you're looking at any child who comes to you with metabolic acidosis. Now, once you have a hyperchloremic normal anion gap metabolic acidosis, look for urinary anion gap, which again is the difference between the unmeasured negative urinary ions and the unmeasured positive ion, or in a simple terms, it's the difference of chloride and sodium and potassium. So clearly in scenario where you have got situations like diarrhea, in which you have got a normal ammonium production, your unmeasured positive ion will go up, and you will have a negative urinary anion gap, which basically means that you have got reversal of anion gap. While in RTA, your ammonium production is impaired, and you will have in that scenario a positive anion gap. So urinary anion gap gives you a clear idea whether you're dealing with RTA versus diarrhea, as we saw in the past case. The 2-month-old boy with failure to thrive in diarrhea, we see metabolic acidosis, anion gap is normal, so this is hyperchloremic. Now you look at the urinary anion gap, and what you see here is that urinary anion gap is negative, which is indicative of a gastrointestinal loss. So this really gives you an idea as to where you are heading. Another term which you can often use is urinary osmolar gap, which is the difference between the measured and the calculated urinary osmolarity. It is again a marker of ammonium production. You have to be wary about UTI, which may cause this confusion. And again, if the osmolar gap is high, which means more ammonia is being produced. So now you know this is RTA. The next question is, what type of RTA are we dealing with? So for that, the most common investigation or the easy investigation is the urinary pH, which should be done during metabolic acidosis. Everybody who has metabolic acidosis should have an acidic urine. Anybody who has a concentrated blood should have a concentrated urine. If your urine is dilute, that is diabetes insipidus. So again, anybody who has metabolic acidosis should have acidic urine. Otherwise, there's a problem in acidification. There are new studies which show 5.3 being a more precise cutoff, although 5.5 is often quoted as well. Infection, however, can cause problems, especially because of urease-producing bacteria, in which they will have a falsely alkalotic urine, and you may mislabel somebody as distal RTA. So be aware of infection when you're looking at urinary pH, as well as exclude dehydration, because they can also cause confusion in terms of evaluation. And so have urinary pH, you should ensure that the urine routine microscopy is normal and urinary sodium levels are more than 25 in that regards. So we have a 3-year-old boy with failure to thrive and hypokalemia. There is metabolic acidosis. There are only 3 causes of hypokalemia with metabolic acidosis, predominantly GI loss and RTA. Now, what we need to see here is what's happening in terms of the anion gap. And what we are seeing in the anion gap is that anion gap is normal. So this is basically a hyperchloremic metabolic acidosis. The next step is urinary pH, which showed it is alkalotic, and one would say this looks like a distal RTA, the possibility. But then we did a workup, fractional excretion of bicarbonate was high. So this looked like a proximal RTA. So now what is the confusion and what are the cause in that perspective? The reason was that in this scenario, the child actually had a urinary tract infection. So if you have a UTI because of a urease producing bacteria, you may have a false diagnosis of a high urinary pH, and this should be excluded before you do the evaluation. The second step is the fractional excretion of bicarbonate. This should be done only after correction of acidosis and the bicarbonate level is more than 20. So what you look at the urine and the blood bicarbonate and the urine and the blood creatinine. In that regard, you can calculate Fe bicarbonate. And if it's more than 10, this is proximal. If it is less, it is distal. But I would say urine pH is a good enough tool to look at. The gold standard, however, to differentiate between a proximal and a distal RTA is a urine to blood carbon dioxide difference, in which you need to really have during metabolic acidosis. You take urine and blood CO2. If it's low, it is distal. It is a marker of distal acidification. If it's high, it's proximal. So just to classify, if your bicarbonate levels are very low, you have hypokalemia, your urinary pH is more than 5.3, you have hypercalciuria, and your Fe bicarbonate less than 5%, you're dealing typically with distal RTA. While if your bicarbonate is towards a milder range, you have a acidic urine with a normal urinary calcium or a high Fe bicarb, you're dealing with a proximal RTA, and this will give you the picture. Now, to classify metabolic acidosis, the first thing to look at is the anion gap. If anion gap is high, you're dealing with other causes like DKA, lactic acidosis, or organic acidemia. If it's normal, you look at urinary anion gap. If it's negative, it is a GI loss. If it's positive, look at potassium. High goes more towards a type 4 RTA. While if it is normal or low, you look at urinary pH, Fe bicarbonate, and urine to blood carbon dioxide difference to differentiate between proximal to distal RTA. So only if you have a normal renal function, hyperchloremic metabolic acidosis, a normal blood anion gap, and a positive anion gap should you think of RTA, and then you can do evaluation from that perspective. So we had this 12-year-old girl with multiple fractures, failure to thrive, polyuria and myopathy, severe metabolic acidosis and hypokalemia. And hypokalemia is a clear clue, as we discussed, that we are dealing with distal RTA usually. So in this regards, we did an anion gap which was normal. There was a urinary anion gap which was positive, which suggests renal tubular etiology. Potassium was low, and urinary pH was on the alkaline side. It was above 5.3, 5.5. So this was suggestive of distal RTA. So this was classically distal RTA. But to make things worse, she had amino acid uria. So this was causing confusion. So we attributed this amino acid uria to hyperparathyroidism, which is a well-known phenomena of Fanconi syndrome induced by hyperparathyroidism. So you have to look at the whole picture to make the diagnosis. Don't just go by one investigation and reach out to the diagnosis. 4-year-old boy with rickets, hypocalcemia, mildly normal potassium. There is a phosphorus which was normal, ALP was high. There was mild metabolic acidosis and a normal anion gap, labeled as a case of RTA. Now, just to give you a clue that most patients who have clear-cut bony deformity, the rickets, if it is because of RTA, you will have a reasonable amount of acidosis if you're thinking of distal, or your phosphorus will be very low if you're thinking of a proximal RTA. So in this case, this sort of a scenario could actually be because again of vitamin D deficiency and secondary hyperparathyroidism inducing a rickets like acidification defect. So don't rush to the diagnosis of RTA also becomes important. Now, what finally is the cause? And we had a discussion, look at a various drug history, especially think of various drugs that can cause this picture. Look at the eye examination for cystinosis, Wilson's, and Jognan syndrome, hearing abnormalities, particularly for the various forms of inherited forms of RTA, and liver examination for various conditions which can cause RTA. So your job is not done by just diagnosing RTA, go beyond in that regards. Workup would require ultrasound, autoimmune panel, hepatitis B workup, Jogren, cilia, and all those parameters become important. Cystinosis and Williams, and type 4 RTA, the workup, of course, is aldosterone and PRA. Now, the last couple of minutes about treatment. So, distal RTA treatment largely is bicarbonate. When you replace bicarbonate, there will be improvement in terms of the potassium level. Your proton excretion will go up, your RAS excess will become less, and your potassium loss will become less. So hypokalemia may improve once you give soda bicarbonate in distal RTA, and that's an important message to think of. Now, what preparation you can use? You have sodium potassium citrate. There is potassium citrate also and sodium bicarbonate. So there's not much difference in terms of potassium or sodium potassium citrate. Sodium may give you a more volume excess, and if there is a secondary hyperaldosteronism, which will come up much better, but otherwise you can use any of that. And now we have got sodium bicarbonate available, which we can use. In distal RTA, we target bicarbonate in the high normal range. Initial dose may be high, as we saw in that case, around 5 to 10 also, but later, once you have corrected, you may require a lower dose of 1 to 2 millimoles per kg per day. The preparation, you can use sodium potassium citrate or sodium bicarbonate. Potassium may be required in the initial phase, but later it becomes less required. And hypercalciuria, you have an important problem to look at. So reduce the salt intake, give thiazide diuretic, otherwise nephrocalcinosis will develop, and potassium salt will be beneficial in this regards. Monitor urinary calcium, annual ultrasound for nephrocalcinosis and renal functions. If your potassium levels are below 3.5 and you have symptoms, you have to give intravenous potassium. Otherwise, you can start with oral potassium. If the potassium is above 3.5, start with sodium potassium citrate. That will be the way. Now, with treatment, you expect improvement in growth, in rickets. Hypercalciuria may increase when you give a sodium salt. So you have to be wary about that. Think of thiazide diuretics, increase citraturia may help. You have to be careful with hypokalemic paralysis. It tends to improve with therapy. Polyuria, once your potassium becomes normal, will improve, and all the deformities will resolve gradually. So RTA is a good thing, but if you diagnose it early, otherwise later you will have a lot of fractures and other problems. In proximal RTA, you would need a much higher dose of bicarbonate, because whatever bicarbonate you give will be lost in the urine. Now, when you're losing this bicarbonate, potassium will also come in, so you will also have hypokalemia. So problem of hypokalemia will get worsened once you treat in terms of proximal RTA, which you have to be careful. So you need to have a much higher dose of bicarbonate, and sometimes adding thiazide amiloride may also help. Potassium requirements are also there, which persist in this regard, and you often have to give phosphate for around 50 milligram per kg per day. There's a risk of hypokalemia. Vitamin D is also required, but the condition tends to improve over time. Monitor 1 week, maintain bicarbonate around 20-22, and then 3 monthly follow-up subsequently. You expect improvement in growth, improvement in bone, but you would need phosphorus and vitamin D as well. You will have improvement in polyuria, but hypokalemia may worsen with therapy in proximal RTA. So just to summarize, RTA should be considered in everybody who has got growth failure, rickets, hypokalemic paralysis, calcification, and polyuria. It should be considered and diagnosed in the presence of metabolic acidosis with normal anion gap, renal function, and low ammonium production, characterized by a positive urinary net charge. Classify according to potassium and urinary pH. And etiological workup is important because you need to have long-term management, and this is not a one-time thing. You have to treat them for a long time. Adherence is absolutely important, and that's why you have to explain and counsel them a lot, because they can often get lost to follow up. So RTA is an important scenario which we should not miss out in that perspective. Once again, I have to thank the entire team of pediatric endocrinology for postgraduates and ISPE for providing me this opportunity to interact on this. And congratulations, Professor Raghupati, Dr. Ahila, Dr. Amarnath, and Dr. Jalvinder for organizing this wonderful program. Thank you.
Thank you, sir. I request you to tell about one word about the FNB upcoming event.
Yes, so we have got some very good news that we have been working for a long time with regards to a FNB program in pediatric endocrinology, and it has been approved by the National Board of Examination, and now they are in the process of inviting the application from the centers, and hopefully central accreditation will be done, and maybe by this year we may have the initiation of the FNB program. It's all because of a lot of work which has been gone on from a lot of ISPE executive and the ISPE members. So this is a good news. We've been waiting for a long time.
Thank you very much, sir. We request you to take FNB seats in future. Thank you. Now over to Dr. Medha Mittal. She is an associate professor. We are going to the ASCII on rickets and RT. It was an excellent lecture, sir. No doubt about it. No words to say. Thank you very much for making it very much clear.
Thank you. Thank you.
Madam, be short and repeated things we can cut short. I request all the participants, especially panelists who are the postgraduates, to interact actively without wasting much time. Madam will be giving few
Very
seconds.
simple. After these excellent lectures, it should be just a cakewalk.
Yeah.
So please volunteer to answer.
Please unmute yourself, all of you, at a time, or one or two. Yes, go ahead.
I've been sharing, so I can't see the list of participants. Dr. Amarnath, maybe you can question from the participants.
Yeah.
Okay, please. So going by the first OSCE, this is a 6-month-old child. He has been admitted. Can you identify the clinical signs? And what should be the underlying etiology? Anyone?
Yes, Sharanya.
Rachitic rosary and widening of the wrist widening hai.
Wrist widening you can appreciate?
Yes,
What else in the
left
chest?
side.
What else in the chest? Please, one person.
Pectus carinatum and rachitic rosary.
Okay, anything else?
Pot belly.
All right, that's it.
Pot
So it is
belly, ma'am.
chest, rachitic rosary, and lateral compression of the chest wall because of the intercostal muscle weakness. What could be the underlying etiology?
Vitamin D deficiency.
Rickets, nutritional
rickets.
Nutritional
Rickets. So it should be calcipenic or phosphopenic?
Calcipenic.
Okay, one true or false. Is serum phosphate low in all rickets? True or false?
False.
False. Dr. Gulab, is serum phosphate low in all rickets?
No, in all rickets, it's not low in all rickets. Only in
Sorry, I can't hear you. Dr. Gulab only, please. Others can mute till that time he is speaking. Gulab?
It's the human phosphopenic only when or in calcific when pH level is high. It increases the urinary excretion of phosphate. In that condition, we can see phosphate level low or hereditary, or as the case is discussed by ma'am.
Anyone else, Surbi? I can see
in CKD. CKD associated
Renal
with rickets
osteodystrophy.
associated with CKD.
Renal
Phosphate will be
osteodystrophy.
high.
So we make the diagnosis of rickets after excluding CKD. Okay, so serum phosphate, Surbi, you want to take this?
Yes, ma'am. Serum phosphate will be low in all types of rickets, excluding CKD.
Yeah, great. So that is true. Serum phosphate is low in all rickets. So don't see a report of phosphate being low and jump to the diagnosis of hypophosphatemic. Serum phosphate is low in all rickets. Okay. Why? As we learned from ma'am's lecture, is PTH is high, so it causes excretion of phosphate. In calciopenic rickets also, PTH high causes excretion of phosphate, so phosphate is low. Moving on to the next one. OSCE 2. I can see another name here, Harshita. Okay, so 1 year, 4-month-old child, his weight is 9.2 -1 standard deviation and height is -3 standard deviation. Calcium is 6.9, phosphate 2.2, alkaline phosphate is 777. Harshita, what is your interpretation?
Anyone, please don't waste the time. Anyone can answer.
Ayushi Verma?
Who is ready?
Low calcium, low phosphorus, and increased ALP.
Okay.
Suggestive of rickets. Vitamin D.
Which type of rickets?
Calcipenic.
Yeah.
Identify the radiological findings. Surbi Gyani?
Ma'am, in femur bone, we can see splaying, fraying, and widening of the ends. And
Okay, Dr. Bhagwan, what is the diagnosis?
Rickets,
Bhagwan
ma'am.
Bharat, rickets. Okay. What further investigation you would like to do? Dr. Ayushi Verma? 25 hydroxy or 125?
Ma'am, 25 hydroxy D.
Okay, if otherwise in cases of nutritional rickets, for a walk-in patient, you may treat even without 25 hydroxy D. But if you at all want to do, you will do only 25 hydroxy D. Okay, so it is generally low in nutritional rickets, and 125 is increase because there is more conversion. Okay, next one. Name any scoring system. Dr. Sharanya?
RSS scoring system.
Thatcher scoring system.
Excellent. So it is a Thatcher scoring system. Would you consider STOS regime? Dr. Yashika Malhotra? Would you consider STOS regime? Is it a good one?
Not usually preferred now.
Why?
Because intermittent therapy से भी मैम उतना ही faster increase होता है
What
in
is the
comparison
risk?
to the single dose.
Excellent.
Nephrocalcinosis का risk ज्यादा है.
We can't say nephrocalcinosis. We can first say hypercalcemia.
Hypercalcemia.
Okay, so don't prefer STOS. What about an IM injection? Suppose I am not, if I give IM injection, does it rapidly restore level?
No.
No, ma'am.
Oral
What
is the
rapidly restores? IM or
oral.
oral. Okay. So what is the best way to monitor the response? Dr. Paridhi Gupta.
Radiological changes.
Sorry?
Radiological changes.
What about serum biochemistry?
Decreased.
Change in ALP levels, ma'am.
Decreased alkaline phosphatase.
Anything else? Anything else? So it is rise in serum phosphate. Okay, alkaline phosphatase would change later only after 4 or 5 weeks. Okay, serum phosphate would improve better first. Next one, this is a 6-year-old boy. He has come with deformity of the limb, as you can see. Okay, people have seen outside and given 2 courses of injection vitamin D 6 lakhs. But X-ray still shows features of rickets. Okay, calcium is 9.1, phosphate is 1.8. Alkaline phosphatase is 756, so it is increased. And 25 hydroxy D has been done, it is 164. Paridhi Gupta, how would you interpret these findings? Sorry, I can see only Paridhi and Ayushi names here.
Yeah, anyone, please go ahead.
Yeah.
Yes.
Calcium level is normal.
White.
Okay.
Phosphate level is decreased.
Just interpret the 25 hydroxy because he has received.
Yeah.
What is the next step you will do? 25 hydroxy D is increased or normal?
Increased.
Increased. Huh? So is it hypervitaminosis?
No, because of vitamin D injections, it may be higher side.
Yeah. So for next step would be to work up for refractory rickets. You will do a venous blood gas and see whether it is RTA or you should go for other forms. Hypervitaminosis, yes, more than 100. Is it vitamin D toxicity? Going back, vitamin D toxicity. So there is a slight difference. You 25 hydroxy D more than 100 would qualify for hypervitaminosis. But for toxicity, there must be hypercalcemia with hypercalciuria, high 25 hydroxy D more than 100 nanogram per ml, and a suppressed PTH. Only when these 4 things are together, you will say it is a vitamin D toxicity. All right. Moving on. 4th case. This is a 28-month-old boy. He has presented with inability to stand without support and short stature. So somebody has seen him outside and received injectable 6 lakh vitamin D along with oral calcium. There's no history of patchy hair loss, no effect of vision or hearing, no vision or hearing problems, and no history suggestive of jaundice or malabsorption. He's a product of third degree consanguineous marriage. Weight and length are both reduced at -3 standard deviation. You can see the blood parameters here. Calcium is 7.3, ionized is 0.7, phosphate is 2.3, alkaline phosphatase is very high, 2327, PTH 398, again raised, 25 hydroxy D, sky high 167, and 125 has also been done because it was being worked up as refractory, so it is 146. Any thoughts on this?
Vitamin D dependent rickets.
Let's see. So this was the X-ray. You can see wrist widening. What can you see here, Dr. Paridhi?
Bowing of legs.
Bowing of limbs.
Right. And the red pointers?
Fractures.
Dr. Chitrakshi is here. Chitrakshi. So you can see fractures.
Yeah.
And the epiphyseal metaphyseal changes here. And here also in the lower limbs. Okay, and there's bowing of the tibia. Okay, next one. So what are the differential diagnoses you will consider? Gulab?
Vitamin D dependent rickets.
Okay. What test would you do further? So vitamin D dependent rickets, after you exclude RTA and must rule out skeletal dysplasia before you think of others. Okay. What test would you do further? People other than Sharanya. Sharanya already has done this. What test would you do further? Dr. Amarnath, could you please call the names?
Blood gas.
1,25. Serum electrolytes.
Okay.
Blood gas analysis.
Blood gas, and further you can do genetic. What would be the treatment plan?
Activated vitamin D.
Then Sharanya, please. Sharanya, you already know this.
Activated vitamin D and calcium supplementation along with it.
Yeah, so active vitamin D. What is the basis of giving active vitamin D, Dr. Surbi? Why do you give active? Why not 25 hydroxy?
1-alpha hydroxylase is deficient in vitamin D dependent rickets. So if you give 25 hydroxy, it will not be converted to 1-alpha hydroxylase. So we have to give 125 vitamin D.
Okay. So what is the enzyme defect? It's here,
1-alpha
hydroxylation, as she said. And what is the defect in VDDR2?
Resistance.
Resistance to endo.
Okay, is it clear to everyone?
Yes, ma'am.
Let's. So this was the clinical exome and it showed CYP27B1 confirming our diagnosis. So next case, 6-year, 10-month-old girl. Others, please answer this time. 6-year, 10-month-old girl, progressive deformity of lower limbs since 10 months of age. Difficulty in walking, but no pain, no fracture, no episode of any tightening of any limb, suggestive of tetany, no polyuria. Received vitamin D, again 6 lakhs and 3 lakhs, injectable, still no improvement. We called the mother also, she has similar picture, she has bow legs. Weight is well maintained at 0.29 standard deviation, however, height is low at -1.9. Okay, you can see the growth chart also. Dr. Divya is here.
Karanya, Paridhi,
Dr.
Dishika,
Phosphopenic rickets.
Okay.
There is late
What
presentation.
investigations would you do?
We will do
What
a
investigations would you like to do?
Calcium, phosphorus, ALP, IPH.
PTH levels.
Yeah, good. So this was the reports. You can see urea and creatinine, they were normal. So this is the importance that you must do urea and creatinine to exclude CKD. Serum calcium 9.4, phosphate is low, alkaline phosphatase somewhat increased, sodium 137, potassium normal. So, and pH was also normal, 7.4. So what does this exclude, Paridhi?
RTA.
RTA. And PTH is 31.7.
Which is abnormally normal.
Yeah.
Could be X-linked dependent phosphopenic rickets.
What does this tell us? That phosphate is not low because of PTH. Right? In calciopenic rickets, the phosphate is low because the PTH is high. But here the phosphate is low, but still the PTH is normal.
Phosphate wasting.
Other cause of phosphate wasting. And vitamin D is 76. Already she received twice. You can see the bony changes here. the cupping and fraying, although they are more marked than calcipenic or less marked?
Less marked.
Less marked.
You can see
Bowing
decrease
of
in
tibia.
angle, here coxa vara and the bowing of the femur. Okay. So PTH is normal, which is the thing that alerts us. Is it calcipenic or phosphopenic? Yashika?
Phosphopenic.
Phosphopenic.
Okay. Is it RTA? Dr. Paridhi?
No, ma'am.
No, ma'am.
No, because there is
Sakshi? Dr. Ayushi, what would you do next?
Phosphate supplementation.
Okay. How much?
phosphate supplements, ma'am. At the
First,
rate of
first you will confirm your diagnosis. You will do the phosphate excretion estimation. You will do urinary phosphate estimation, how much the child is excreting. Okay. So what is the formula to calculate the fractional excretion of phosphate? Dr. Surbi?
Ma'am, this will be urinary phosphate into serum creatinine upon
Creatinine
into
Urinary phosphate into serum creatinine. Okay.
ma'am, urinary
phosphate
into serum creatinine upon urinary creatinine.
Okay. Let's see. All right. So this is U upon P for phosphate upon U upon P for creatinine. All right. So this is easy to remember. This multiplied by 100. Okay. For this you can use for any estimation for biocarb or phosphate. All right. So urine upon plasma values for phosphate upon urine upon plasma values for creatinine into 100. So what is the formula to calculate TRP? Tubular resorption of phosphate. Anyone else? Dr. Divya, Dr. Anand? Dr. Sahil? So 1 minus fractional excretion of phosphate is TRP. How much is the normal TRP? Dr. Chitrakshi?
15.
Sorry? Anyone else? Please answer. We just saw there. So it is 88 to 95%. So whatever is phosphate is excreted comes at the tubular level. Most of it is reabsorbed. So if the tubular reabsorption of phosphate is 88% at phosphate 2.1, how would you interpret it? The seventh one?
Less absorption of the phosphate from the urine.
Yeah, so this is good. This is normal.
TRP should be
TRP
higher
is
at the
88 to
outside.
95 is normal. So 88.3. Is it normal, Gulab?
No,
How would
ma'am,
you
it should be
interpret
higher. It should be
Yeah,
higher
why
at
should
the
it be
phosphate.
higher? Very good. Why should it be higher?
There should be increased absorption of the phosphate to maintain the phosphate in the blood level.
Exactly.
So TRP
Exactly.
should be
Yeah, so TRP has to be interpreted in the light of serum phosphate. And how do we calculate the TMP GFR? By the nomogram. Okay. So what is the normal value? This you must remember. You remember, Gulab, what is the normal value?
2.5.
Okay. So these are the normal values here, 2.8 to 4.4. And this is the nomogram. Outside values showing in milligram per dl. So 2.8 to 4.4. Okay. Next one. So this is MCQs. You are all fond of MCQs. The basic pathophysiology of rickets. Ayushi Verma. Defective apoptosis of osteocytes or defective apoptosis of chondrocytes?
ma'am, defective apoptosis of chondrocytes.
Excellent. Okay. So PTH, action of PTH. It increases phosphate excretion or decreases phosphate excretion? Dr. Anand.
Increases phosphate excretion.
Excellent. So you have all heard, ma'am, carefully. In hypophosphatemic rickets, where is the problem? Increased excretion of phosphate in proximal renal tubule or increased excretion of phosphate in distal renal tubule?
Proximal renal tubule.
Sorry?
Proximal renal tubule.
Yeah. So there is loss of phosphate at the level of proximal renal tubules where there are receptors for NaPi2A and 2C to reabsorb the phosphate. The serum level of vitamin D considered sufficient. We all are fond of giving vitamin D, but we should know what is the normal level and what is the units. Both we have to
20
see.
nanogram.
So nanogram per ml, the usually used values with us. What is the normal
20.
serum vitamin D level considered sufficient?
20 nanogram per ml.
Yeah, excellent. 20 nanogram per ml. This one is this growth factor is increased in hypophosphatemic rickets, and there is phosphate
That's
waste
good, sir.
because it is not reabsorbed.
FGF 23.
FGF 23.
FGF 20.
Excellent. So next one, the biochemical hallmark of hypophosphatemic rickets with increased FGF 23. Pick one of the three, A, B, or C. Do you want to see 25-hydroxy D? Is it required to be
Option
seen?
A, ma'am. Option A.
Option A.
Because 25-hydroxy D does not need to be seen. Because if it is low, it is definitely, we are not thinking of hypophosphatemic. So option A, huh? So
Option A.
yeah. Why is 125 low?
With negative feedback for 1-alpha hydroxylase by increased FGF 23.
Oh, no, because of FGF 23, it
Inhibits
yeah, it
1-alpha
inhibits the alpha
inhibits
hydroxylase.
1-alpha hydroxylase.
Yeah. Apart from causing phosphate wastage. So how should PTH sample be sent? Already I have written the answer in EDTA on
EDTA on
ISAPE.
ISAPE immediate drugs.
Yeah. So next one. So now we have a case of hypophosphatemic rickets. What is the treatment?
Phosphate.
Anyone?
Depending on the age of the patient, we have to supplement the phosphate.
Phosphate as well as alpha calcidiol.
Active form of it.
Okay. Phosphate and alpha calcidiol both. How will you monitor the treatment? Serum phosphorus or alkaline phosphatase?
Alkaline phosphate.
Alkaline
Phosphate over
phosphatase.
UTR.
Yeah, excellent. If there is no improvement, what newer treatment can be considered?
Burosumab.
Yeah, wonderful.
Monoclonal antibody.
Here are the answers: treatment, oral phosphate, and active vitamin D. One value for phosphate you can remember is 50 nanogram per kg per day. And alpha
Monoclonal
calcidiol.
antibody against.
Yeah, what is the need for giving alpha calcidiol? The problem is phosphate. Why do we need to give alpha calcidiol?
FGF 23 is increased, which leads to a decreased conversion of 25 hydroxylase vitamin D to 1,25 hydroxylase vitamin D, as it inhibits the action of 1-alpha hydroxylase.
So what? All right. Further, the alpha calcidiol will limit the increase of PTH. Okay. So how would you monitor treatment? As we said, alkaline phosphatase, and you have to also monitor urine calcium creatinine ratio. Okay, because there can be increased excretion. Borosumab, monoclonal antibody approved for X-linked hypophosphatemia. Should we go on? Here is the next one. The 6-year, 10-month-old child with this limb deformity. Can anyone tell what type of limb deformity is this?
Windswept.
Yeah, wonderful, excellent. This is windswept. What is the meaning of windswept?
One leg
Impairment one with valgus at the other.
Sorry, please.
Valgum in one leg and varus in the other leg.
Yeah. Okay, so it is like valgus in one leg and varum in the other. So this is a limb deformity since early childhood and it is progressing. Child has received 2 courses of vitamin D oral. 5 sachet and 2 such courses. Non-consanguineous marriage, no similar history in siblings. And after digging further the history, we found that there is increased urine frequency and volume. Weight is at -0.5 standard deviation and height is at -3.73. Here are the reports. The calcium is 8.3. Phosphate is 3.3. Alkaline phosphatase is 1217. Sodium is 132. Potassium is 2.9. So apart from the usual calcium phosphate, alkaline phosphatase, the sodium and potassium were also done, and we found that potassium is low. Okay, so what does this alert us to?
RT.
Yeah. So what further investigations would you like to do?
Blood gas.
Blood gas analysis.
Okay. Dr. Vaishali, what is the formula for plasma 9 gap?
Sodium minus chloride and bicarb.
Okay. Just a second.
Formula for urinary anion gap. Next.
Sodium plus potassium minus chloride.
Oh. What is the formula for urine anion gap, you said?
Sodium plus potassium.
What are the expected values in RTA?
Normal anion gap.
Normal anion gap.
And positive
urine?
Positive urinary anion.
Yeah, so the urine anion gap doesn't differentiate between proximal and distal, so to say. Okay, differentiate between how?
Urine pH.
This was the values here. The pH is low and bicarb is low.
pH
Let
is
us see
high.
whether it is proximal or distal. So urine pH is more than 5.5.
5.
So it is
Distal artery.
Distal.
It goes with matching distal artery. Okay,
Okay.
fine. Bicarb excretion is more than 15%. What would you suggest?
Proximal.
Proximal RTA.
Excellent. If there is hypercalciuria, what would they suggest?
Distal artery.
Oh, this was easy. And glucosuria, amino aciduria?
Proximal.
All right.
Proximal artery.
Yeah. And if urine to blood PCO2 gradient is less than 10? How much is the gradient usually? Usually there is CO2 is high in the urine, more than 70, and the gradient is more than 20. If it is less than 10?
Distal artery.
Okay. Sorry, answer didn't come. Okay, urine pH measurement. Any precautions?
Rule out any UTI.
Very good.
Normal.
Urine pH during the time of metabolic acidosis.
Yeah. So freshly voided urine and use a pH meter, not a pH strip, and with other precautions you have mentioned. And any precautions to take for fractional excretion of bicarb?
Measured only when metabolic acidosis is
Yeah. Resolved. Yeah. Serum bicarb is near normal, more than 80. Thank you. These are all. Over to you, Dr. Amarnath.
Thank you very much for whole team of Meda Mittal, madam. So it was an excellent presentation. So,
Thank you.
so we'll complete just within 1 minute. What are the questions has been asked in the last 2 years? Rickets, they have asked mainly in vitamin D metabolism and physiology, and all types of rickets you are able to see here. And not moving. In case of RTA, they have asked all the type of renal tubular acidosis, especially differences between proximal and distal RTA. Yeah. So pathophysiology and basis of clinical and radiological features. Most important thing is they are asking questions by giving the few examples and history and symptoms. We should be aware of that. So hypervitaminosis D, they are asking. Again in RTA, classification, outline, treatment, approach, pathogenesis, management of distal RTA. Describe test to evaluate. As madam has discussed in detail, we should be very much aware of management of both distal and renal tubular acidosis. Thank you. So I thank everyone. Over to Jaivinderji and Raghupati sir. Yeah.
So we can have some learning pearls from Raghupati sir before we conclude the session.
I just want to say that it's an excellent session and a lot of useful points. And I'm sure the exam going students will agree that it was most useful with reference to their performance or their expectations in their exam. And thank you, Amarnath and Dr. Jaivinder and all the speakers and the presenters for giving an excellent session. Thank you all very much. And I am very impressed with the continued enthusiasm. And we need very tough ringmasters like Amarnath. Thank you very much.
Sir, I request you to tell that example of the patient of the hypophosphatemic rickets. He was carrying the phosphate on his load on his back. Father, you remember?
Yeah. Initially, when phosphate adphos and all was not available, we used to make phosphate mixture in Vellore, in the Vellore pharmacy, because we had an Australian pharmacist in charge. And these things used to be bottled solutions. And we always used to say this will sediment, and every time you have to shake the bottle and all that. And people could not travel long distances. So they used to carry 3 months supply, sometimes 6 months supply. You can imagine what a lot of luggage they had to take all the time. And later on, I made it as packets of salt itself. And I told the parents to make 500 ml solution at a time. But now AdFos is available and it's no problem at all. And even now, the phosphates, monosodium dihydrogen phosphate, disodium monohydrogen phosphate, are all available from the chemist. And they're much cheaper. Only thing is you have to find the right chemist. Anyway, AdFos results are quite good, and they're a little more expensive than what I suggest, but it can be done. Okay. Thank you all. Thanks again for
Yeah, I thank you everyone, especially
Thank you,
Javinder
sir.
ji for taking care, and Dr. Medha Mittal and team. It was an excellent task out of all the sessions, very much interactive, and most of the new things has been exposed. Thank you everyone,
Thank you.
especially
Thank you,
Ankit
everyone.
and his team for back end support. I thank Ahila Madam once again, all the speakers, experts, and all the participants who stayed till the end. Almost more than 100 were there. We are there. Thank you, everyone.
Thank you so much.
Thank you. Thank you. Good night, everyone.
Bye, everyone.
Bye.
Bye. Good night.